May I express my gratitude to the organizing committee for inviting me to deliver this short lecture. I was told to give a long lecture, in fact, 1 hour on trauma, hemorrhage, and shock. But I heard that it will be superfluous on my part to repeat very many things on and on, because most of the part has been probably dealt with, either hemorrhage or shock. But I'll do my part. Talking about obstetrics, because I think the early morning everything had been in obstetrics. When we were students, we were told in obstetrics it is watchful expectancy and masterly in activity. And I found Professor Disha talking about a lot of activities, particularly when you are dealing with issues and problems, which comes unexpected. Very often the problem in obstetric emergencies are unexpected emergencies. You can't just predict, and 2 lives are at risk. Sometimes the hospital is at risk. Sometimes the doctor is at risk. This is what we find of late. So we have got a God call. I think most of this hospital has got it, and we call it code blue. And that is a fantastic thing to overcome the immediate concerns of any untoward event which happens to a patient. Without much ado, I will talk about polytrauma. Anybody can tell me what trauma is, what your understanding of trauma? If I ask questions, either it's becoming didactic lectures. I don't expect answers either, because when the stomach is empty, the skull also remains empty, and the gathering of knowledge becomes less and less. So I'll be as precise as possible. Trauma is nothing but a transference of kinetic energy. Any energy transferred onto your body, no matter whether it is a knife thrust on your body or something falling on your body, when a kinetic energy which surpasses the tensile strength of your tissue, your body is traumatized. I'm not talking about heart trauma. Don't take that part of it. When you have an external force acting upon your body, each body part has got a particular tensile strength. And when that tensile strength is exceeded, that particular part will just dissipate or break. You will find that the skin has got a better tensile strength than bone. That's why even when a bone is fractured, you will find the overlying skin is intact. Perhaps the best structure in the body, which has got the maximum tensile strength, is teeth, because teeth can even grind bones. So I'll leave it on that. Trauma does not occur by and large on a single area. You find that there are innumerable causes of trauma. It's man-made problems, homicidal attempts, and of late we find that, not of late, you take a newspaper every day, you will find that the front page is filled with these traumatic experiences of the world. It could come as natural disasters. Just imagine the situation at the border of Turkey and Syria, an earthquake. The natural disasters come without warning. A flood, a typhoon, all these things, now we have got satellite warning, but nothing as regards to an earthquake, which produce such devastating issues. That's about trauma. So what trauma actually is? Not moving. Hello. The movie in the okay. So it's not a single organ that is involved. It's not a single area that is involved. It's multiple areas that get involved in polytrauma. So by definition, polytrauma means a syndrome of multiple injuries. It can occur in various places of the body with systemic traumatic reactions. The reactions can be far-fetched and far wide than the local site alone, and can lead to dysfunction of or failure of organs which are far removed. You may have an injury in the femur or the leg, and ultimately you find that the kidney is damaged because a lot of myoglobin is released and the kidney tubules are damaged, and you probably end up with a renal failure. It is number one cause of death among the what shall I say, the active group of people, the younger age group of people, 18 to 44 years. And it is the third most common cause of death in all ages put together. I would call it as a global pandemic. Unfortunately, we don't have a vaccine for trauma. We have vaccine for everything. At least they are attempting to make vaccine, but for trauma, there's no vaccine. So death in polytrauma usually occurs at 3 stages. It's called the trimodal death. The death at the site, you can't help it. Nobody can help that particular type of death. But then the early trauma death or the second peak of death, we'll come to that very shortly. And the late death, which Ma'am was talking about, sepsis and shock. The first death occurs when you have got a severe head injury. Something runs over your head. Nothing can help. It's as good as you're decapitated. So severe head injury, a brainstem injury which prevents you from breathing, your cardiac activities are lost, and you remain brain dead. A high spinal cord injury where again the breathing is affected. The heart and major vessel, you have got a run over the chest. You can't help it. The heart sometimes ruptures and you just can't save the patient. Or massive blood loss at the site. Similarly, when air traffic accidents occur, particularly in the air, mostly they die, most of them they die in the air because of the pressure changes. The lung actually bursts open and you die in fact before you are burnt. So I'm actually avoiding much description about burn injuries and blast injuries here, but nevertheless it's all same. It is a kinetic force that is acting upon your body. Now, the second peak is the one which is a preventable one, where you have got a continuing hemorrhage or you have got a respiratory difficulty, and you are probably likely to save these sort of patients. There's a second mode where if you delay in instituting treatment, you probably tend to lose the patient. And the third peak of death is when multiple organs get damaged because of ongoing sepsis or new sepsis letting in, maybe due to various sources. It may be a hospital-acquired infection through the cannulas or tubes that have put into the body, or perhaps the damage to the organs that have taken place. So if you've got an intestinal injury, you have got peritonitis taking place, and that sepsis can go on in spite of the antibiotics. We presume that we have mastered infection with the help of antibiotics, but these organisms have been smart enough. They had been with us or in this world even before we were, trillions and trillions of years, and they know the trick to survive. We don't know the trick to survive. So aims in the management of a trauma, basically, let us put in very simple terms, it is life salvage. We have to save the life, that would be the first aim. If a limb is to be saved, that has to be, but at the expense of a limb, if the life can be saved, life should be saved. And salvage of total function, if possible, that would be the ideal goal. If you can put back the patient, back to the society, back to his family as a good, helpful social being, that would be the ideal one. And often we may be able to do that, but sometimes we may fail as well. Life salvage, because as 50% of the death in trauma occurs before the patient reaches the hospital. This imperative is most important to identify the nature of trauma and shifting to the places where tertiary care or secondary care can be effective. Because at the site, we may be able to do only minimum. We may be able to protect the spine, cervical spine or the lumbar spine. We may be able to remove foreign bodies from the mouth or nose, at least prevent them from aspirating, a pressure over a dressing site or a bleeding site, etc. And then shift the patient as early as possible. So 30% occurs within 4 hours of reaching the hospital, which is this group that we must concentrate upon. And 20% occurs within the next 3 weeks, as I told, as a third mode of death. So if preventive measures are taken, 70% of the death can be prevented, meaning 30% we will lose still in trauma cases. Who treats a trauma victim in the hospital, once in the hospital? Because at site, nurses may sometimes be required to take care of. There, I would say that the most important thing is the ABC or whatever the primary survey is very important, which had been oft repeated here earlier. I saw that. We require a team leader, we require neurosurgeons, orthopedic surgeons, thoracic surgeon, accident and emergency medical officer, urologist, and anesthesiologist. This comprises a trauma team, but at a given time, all need not be present at the same venue, but each one may be called in depending upon the situation that they have to tackle. The 4 interrelated stages are: we require a rapid survey with a simultaneous resuscitation. The goal of any treatment for that matter, or any successful culmination of events, is resuscitation, recognition, and repair. It need not go sequentially, it can go hand in hand. The 3R, the mnemonic, is so very important, that resuscitation of a patient, recognition of the defect, and repair of the problem stands as the primary aim in emergency deals. So we immediately have, the first thing is a rapid primary survey, which will come very shortly to. And the detailed secondary survey, once the patient is stable, and constant reevaluation and initiation of definitive care. The constant reevaluation is so very important. I still remember our old neurosurgeon saying that a man scan is better than a CAT scan. A CT scan, the earlier terminology for a CT scan was a computerized axial tomography, or the short form was CAT scan. The man scan is more important, that you have a constant observation of the patient, which can easily detect certain changes, which can probably save life right in time. So the definitive care is done once you have got a definitive issue, a definitive diagnosis arrived at. The pre-hospital phase, as I said, the basic skills are important, where the maintenance of the airway is very important, cardiopulmonary resuscitation, fluid replacement, reduction and splintage of fractures, and perform primary survey of the patient. This is the pre-hospital phase that we have to do. A fracture can be splintered. There is no hurry to deal a fracture at all, unless a blood vessel nearby is involved. Cardiopulmonary resuscitation, I think a BLS training has been given for everybody who is into the medical field. So it is important and imperative, particularly when there's a cardiogenic shock, the patient is not breathing, the pulse is absent, but the primary event of cardiac massage and airway management is very, very important. At the site, fluid replacement may not be very easy, but at least we can probably stop hemorrhages. The triaging is a term used to sort of grouping the people according to the severity of the injury. So it's very important that in the emergency room, to identify which person requires the earliest care and which one can wait. So actually the basic system is to prioritize the treatment in a trauma case, and that is the crux of what we call as triaging. That to sort out the patients into those who need critical care, and that is very important. So triaging abroad and all, we find we get got color coding. You have got a black code for people who are dead, no need to bother about it. But the red one, the red code is the most important one. The green one can wait. The yellow is the intermediate type. So color coding is a good method of managing this triaging system. We are talking about the golden hour in case of postpartum hemorrhage. Same thing applies here because the golden hour is so very important that the first hour where you can probably control bleeding, take care of the airway, the life of a patient can be saved almost 90% of time. So chances of survival diminishes once this delay occurs. Beyond the gold is very costly now. So I don't know what platinum costs like. So platinum is the first 10 minutes. The platinum time is very, very important. This is the first 10 minutes of the golden hour that may be used on-scene activities. The on-scene activities, the most important thing is airway and circulation. So the primary survey, I'm sure this has been dealt with umpteen number of times. I will come to the airway maintenance and control of cervical spine. Because any patient who is traumatized above the clavicle is presumed to have a cervical spine injury, and protection of cervical spine is mandatory in such situation. No matter how you do, if whatever is available, a Philadelphia collar would be the ideal one if you got it at hand. But anything, even 2 bricks kept on either side, in situations where nothing is available, could at least protect the spine. It's very important. So breathing and oxygenation, circulation, control of bleeding, the disability part, every aspect I will come very, very shortly. So the things that probably can kill the patient, I can identify in the primary survey, which can affect deleteriously the patient, is airway obstruction. Time and again, we have seen patients being shifted in an ambulance in supine position following head injury and unconscious patient. They vomit, they aspirate, and they die. So it's very important that the airway obstruction is identified umpteen number of times. At postmortem, we found out the head injury was so trivial, but the patient has aspirated, asphyxiated, and died. A tension pneumothorax is whereby air collects in the pleural cavity, completely altering the mechanics of ventilation. So also a large amount of blood in the pleural cavity. All these things can lead to our immediate primary survey that we can identify and treat to save the patient. The signs of obstruction, airway obstruction is simple thing is to look, listen, and feel. Looking for agitation when there is breathing difficulty, patient will be agitated. Deformity in the chest wall, and listen for hoarseness of voice, particularly when you've got a stertorous breathing, you find that the airway is partly blocked. When to ventilate, when a patient is apneic, when there is hypoventilation, when there's a diaphragmatic injury, a head injury with a coma scale less than 8, a flail chest where the chest moves inside during inspiration and affects the physiology of respiration. A high spinal cord injury because the intercostal muscles will be damaged, and also in situations of hypothermia. Umpteen number of ways of maintaining the airway, but the most important thing is to see that the oxygenation is well maintained. So we have, as we said, that the cervical spine protection, if best, can be done by a Philadelphia collar. The causes of major bleeding could be external bleeding, obvious, but thoracic bleeding, pelvic bleeding, these are 2 things which remain concealed. The greatest number of loss in autopsy that I have seen in my lifetime had been due to pelvic bleeding and thoracic bleeding. Because particularly in children, it's very obvious to identify an abdominal bleed, a bleed into the cranial cavity, etc. Yeah, we are very much conscious about it. But time and again, we have lost patients without being looking into this particular aspect. But I think of late, what has happened is that when the patient comes into the emergency room, the most important thing that is being done, apart from all this survey, is what is called as EFAST. That is an ultrasonic evaluation of an emergency ultrasonic evaluation of the abdominal cavity, the pelvic cavity, and also to the pleural cavity directed towards the heart. So any collection of fluid in these cavities is deemed to be an important event. Long bone fractures can even contain a liter or a half of blood, so that there could be sufficient amount of blood loss because of that. Intra-abdominal bleeding can be easily confirmed by clinical findings, ultrasound or CT scan, and an emergency laparotomy can sort out the issue. The method of the circulation, the best option is to have a large bore cannula set into any available vein. You don't have to worry about identifying the internal jugular vein with the help of a sonic aid, etc. Any available vein, if you can access, put in a 16 or an 18 gauge cannula, and then any fluid that is available other than distilled water, please instill into it. Crystalloids or colloids, no matter what is available, but ideally we will start with a balanced or solution, what's called a renal lactate solution. The disability part is the one that we can't come across regarding the neurological activity of the patient. So we say that the ABPU, as the patient is very alert, you know that the neurological activity, the cognizance, etc., is a factor of the cerebral cortex. So that's good. The response to vocal stimuli means it can hear and respond. Similarly, response to painful stimuli means the conscious level is becoming worse, and unresponsive is a bad sign. So the AVPU concept has to be drilled into you to identify the disability part. And the Glasgow Coma Scale is so well known these days. And a Glasgow Coma Scale less than 8 is detrimental, below 3 is almost fatal. So the various aspects that you look into, the eye opening, the verbal response, and the motor response, and the total scoring is about 15. And if a 15 if a score is there, the person is absolutely normal. The strategies of in patients with head injuries, chest injuries, and abdominal injuries all come once you have got a specific diagnosis made. This diagnosis is made basically in a secondary survey. Don't rush the patient to any situation of evaluation unless the patient is stabilized. If the patient is not stable, in spite of a good circulatory attempt to improve circulation, then it is an indication to explore immediately in the emergency room. So there is no delay in such a situation. You may be having an aortic rupture, or you may be having a cardiac rupture. You cannot keep on continue to improve the circulation and do investigations. You probably will have to rush in fast. The secondary survey is done only when the patient is absolutely stable. There's a head-to-toe survey, physical examination, and you can do all and sundry evaluation, imaging, etc. Where these days you can identify the grade of injury and see whether the patient needs an emergency surgery, or you can deal without doing an emergency surgery. The 0-hour fixation, I'm talking about the orthopedic fixation, particularly important when major vessels are close by in fractures or comminuted fractures are there, which can impinge upon major vessels, and the vessels can be damaged. It is better to fix such fractures. Spinal injury, one has to be very careful in shifting the patient. They are basically shifted on what is called as a spine board. If the spine board is not available, at least 2 logs of wood is enough to bind the patient down, but don't fold the patient. Today we have got 112 or 102, I don't know the number, that you die, you get all ambulances rushing to the place. But I have seen patients who have had trivial spinal injury, buckled into an auto rickshaw, who made a complete paraplegia by the time they come to the hospital. So today things are much more different because the transport of the traumatized patient is much more streamlined. A word about damage control surgery. When you have got a patient who has got very critical, don't try to do heroic surgery to control the bleeding, etc. The classical example is when you have got a massive rupture of the liver. And you cannot do anything because liver is an organ which is surgery on the liver is fraught with so much of difficulties and danger. All that you have to control is to control the bleeding. We say that in damage control, in abdomen, we control the leak, we control the bleed. And you can probably resuscitate the patient in between. And at ideal time, you can have a relook. And by the time things will be much controlled, the hypothermia will be controlled, The coagulopathy will be controlled so that you can operate on a patient who is a little more stable rather than an unstable person. In a stable patient, there is no life-threatening injuries. You can do an early total care. Whereas you've got a borderline patient initially responding to resuscitation but can deteriorate, there you probably have to wait for improvement and do the necessary things. But an unstable patient is remaining hemodynamically unstable. That's where we require a damage control surgery, damage control techniques. And in an extreme situation, in spite of all these things, you probably is likely to lose the patient. Time and again, we have seen these situations. They are taken in an intensive trauma unit and treated, but then the survival of such patients are far remote. When you talk about one of the investigations in a patient who is either in shock or septicemia or traumatized is the serum lactate levels. It's a very important one. That if you've got a serum lactate less than 2.5, the chances of mortality is 5.4%. But just look at it. If it is more than 4, that is what it means. The serum lactate, lactic acid, I don't know if you learn biochemistry. Lactic acid is an end product of anaerobic metabolism. That means you are getting energy without the help of oxygen. So in the anaerobic metabolism is taking place, the end product is lactic acid. It produces severe acidosis. And acidosis is bad. Hypothermia is bad. Coagulopathy is bad. So when you have a serum lactate mounting up, you know that you are losing this patient by and by. They may go into diffuse, disseminated intravascular coagulation. No matter what you try, they bleed. The DIC has been aptly characterized as death is coming, not disseminated intravascular coagulation. In musculoskeletal injury, save life, first instance, save limb, save joints, and restore function, we have already said. Ladies and gentlemen, perhaps trauma is, as I told you, to sum up, is of a pandemic proportion. But most important thing is to identify the intensity of injury, consider about the golden hour. The most things by which you can lose the patient is airway and hemorrhage, bleeding and airway. So if you can have a good idea of controlling the airway, identifying problems of the airway, and controlling the hemorrhage, I think we can bring back quite a number of patients to useful life post-operatively or in due course of time. So hemorrhage can be short because since morning I've been keeping on hearing about antepartum hemorrhage, postpartum hemorrhage. The contents, I'm just trying to talk about the types of hemorrhage, the WHO grading of hemorrhage, the classification of hemorrhage, the common causes, the signs and symptoms, and how you manage. To begin with, ultimately, I will say that I've been hearing the earlier professor talking about the various tamponade method of controlling bleeding. It's one of the simplest measures of controlling bleeding is to position and pressure. It has been said that you can just apply pressure over a bleeding point and religiously apply the pressure over 5 minutes. You can even control bleeding from aorta. People have done deliberately, cut open the abdomen, removed the kidney, did not ligate the artery, asked the assistant to apply pressure on the renal artery and the renal vein, and went in, he had a fag and had something to eat as well. When he came back, the assistant was taking off the mop and they found that everything has stopped. Because one good thing for the bleeding is that God has created 2 mechanisms for the bleeding to be controlled. One is constriction of the blood vessel. The blood vessel goes into spasm and reduces the human size. Second thing is the God-given system of coagulation. So these 2 things, if doesn't work, you are in for difficulty. That's a situation that you probably land up in late cases of PPH, or where the fibrin, the clot that is produced is getting lysed. Fibrinolysis occurs. Fibrinolysis syndrome, that is where you get into difficult bleeding and losing the patient by and by. So hemorrhage, as you know, two things have to happen. You must have a vessel injured and the blood has to come out. It has to get extravasated. Okay. Forget about the composition of the blood. If you want to know more about it, right, it has got plasma and formed elements. The plasma takes the lion's share, 59% of it is by plasma, which contains, of which the biggest share is water. So we are made up of water mostly. We came from sea, and obviously we are made up of water. The clotting mechanism, as I told you, I'm not going to get into details. I'm sure you're all most of them are famished. This is a simplest way I can put the clotting cascade, the coagulation cascade, and where it can be blocked as well. Okay, the heparin blocks in two places, and that is where you want to prevent thrombus formation. But in hemorrhage, we don't want that. We are not going to use heparin. In hemorrhage, we are trying to stop them. That should be our goal. Okay. Leave alone the pathophysiology, the body has got a lot of mechanisms to overcome hemorrhage. When you lose fluid, the body tries to take in fluid or to improve the circulation by adjusting the fluid volume from various places. The splanchnic circulation, that donates. The venous spasm, that donates. But when a time comes that you also try to improve the circulation by venoclysis, and then if a continuous process of blood loss occurs, by and by you will lose the patient. The types of hemorrhage, you know that according to the timing of hemorrhage, you classify it as a primary, reactionary, or intermediate, or secondary. Primary hemorrhage is something which happens at the time of surgery or when the injury is taking place. The immediate, intermediate, or the reactionary hemorrhage is occurring when your systems are trying to compensate the loss, and your blood pressure starts coming up, and small leaks which are closed by spasm or small coagulum may probably open up. The secondary hemorrhage is something which happens late in the time, maybe about a week later or so, when sepsis occurs and the vessel just opens up. Necrosis occurs of the blood vessel and it can open up. External and concealed hemorrhages. External hemorrhage is very easy to identify. Somebody is bleeding, and I think it's very obvious, it is evident. Whereas internal hemorrhages, concealed hemorrhages are dangerous. Ectopic pregnancy, for example, is a variety of concealed hemorrhage. The patient may come with abdominal pain, pallor, and those are classical symptoms. But then concealed hemorrhage is something which can reveal later sometimes. You may have a bleeding into the gastrointestinal tract, and we have seen patients suddenly falling down because of the hypotension, and maybe after 24 hours they start presenting melena. If they're vomiting blood, it is very obvious, but if you've got a massive hemorrhage occurring into the intestine, then it is revealed later. Initially it is concealed, but revealed later. According to the blood vessel that is involved, you can have arterial bleed, capillary bleed, or venous bleed. Capillary bleeding is a gentle, steady oozing. Is from the smallest of the vessels in the body. The venous is not blue in color as people think. It is still red in color, but then the flow is steady. Whereas arterial bleed comes in spurts. If you look at the operated site, you will find which is vein, which is artery. Of large veins, I have to say one thing, that when you have large veins in the neck, probably damaged, it sucks in air because of the negative intrathoracic pressure, and you probably suck in a lot of air also and can cause fatal air embolism. So beware of injuries in the neck, particularly when large veins are exposed. The primary, reactionary, secondary I have already mentioned about. Revealed and concealed hemorrhage I have mentioned about. Regarding the WHO grading, the WHO standardized grading scale to measure the bleeding. Grade 1, you got on the very small bleed, petechial. Grade 2 is mild blood loss, and the grade 3 gross blood loss. These gross, mild, etc. It's very difficult to identify unless you have got certain system to find out. So in a class 1 injury, classification hemorrhage, but a class 1 injury where about 15% of the blood volume is lost. Usually the compensatory mechanism take place and you hardly find any systemic changes occurring place. Whereas in class 2, you've got more than around close to 30% of whole blood volume is lost. And in class 3, about 30 to 40%. And in class 4, more than 40% of blood volume is lost. So in class 4, you find the symptoms are different. The air hunger, the vasospasm, the cold sweat, as you can classically say. The sweating is because of sympathetic stimulation. The body is cold because there is no capillary circulation taking place. That's a classical cold sweaty cough. So it can be managed by medical measures to identify whether the patient has got any bleeding diathesis. But as far as the surgeon is concerned, the surgical bleeding occurs at the site and one must be adept in controlling the bleeding. As I said, the most important measures to control the bleeding is elevation, position. Whenever there is a venous bleeding, you elevate that part, the bleeding stops. People do panic when they find bleed. Similarly, an arterial bleed can be controlled by simple local pressure, or if it is a limb, you can apply a proximal tourniquet. A word of caution: when you apply a tourniquet, you should note the time the tourniquet has been applied, because each part of the body has got a particular time for which they can withstand ischemia. So I think of late you must have heard about a young footballer who lost her limb because a tourniquet was applied, and the time nobody knew about the tourniquet was applied, and something has been done for her, and later that they come to know that the tourniquet has been applied, the limb had been ischemic by the time it was discovered, and she lost her limb. That's pretty sad. So I will not take up much of your time. In summarizing, hemorrhage is a loss of blood from any blood vessel due to some trauma or injury. Spontaneous hemorrhages can occur, but that is again when the pressure within the system is more than what it can withstand. So my first sentence saying that a trauma is a transference of kinetic energy. So you've got the pressure within an artery, which is more than what the wall can sustain, and the wall gives way, and you have got hemorrhage. There's no trauma involved, direct trauma involved. So it may also occur due to some bleeding disorder or tumors which can bleed inside. Bleeding may be external or internal, as I told you. Signs and symptoms depend upon the extent of blood loss, as is classified as type 1, type 2, type 3, type 4. Depending upon the amount of blood lost, the symptoms do vary, and WHO has set a standard grading the schedule to assess level of blood loss. And uncontrolled bleeding can lead to hemorrhagic shock and even death. I think I was asked about to talk on shock. A major has been dealt with by the preceding speaker. So shock is a situation where, due to one reason or other, there is improper oxygenation of tissues. The microcirculation is affected, and innumerable causes has been mentioned about it. So immediate measures are taken to control bleeding, and blood products and fluids are administered to replace fluid volume. The coagulation products, if you have a loss of products which are necessary for coagulation, we've got, as the previous speaker was talking about, we've got a lot of recombinant materials available to supplement agents which are responsible for bleeding and which are called deficient. Okay, patient should be monitored continuously and assessed to check his response to the therapy. I think I will stop talking about it. I am sure I'm leaving a lot of lacunae. those who have at least had food can ask some questions.
Thank you, sir, for your valuable session. Any queries on the side of audience?
I was impressed by the use of the Sengstake and Blackmore tube for controlling bleeding from the uterus. We were taught Sengstake and Blackmore tube for esophageal bleed. And when I find that the second human can control bleeding from the vagina as well, that's news to me. The other type of course, basically it is a system of applying pressure, tamponade. So if you know the principle that pressure can stop hemorrhage, you can apply it, except in the neck. If you apply neck pressure on the neck, the bleeding may stop forever, and you may be asphyxiated, and the patient will die of asphyxiation. That's the only place where we should not apply pressure, and we should be able to stop the bleeding by any one good means. Thank you for your patient care.
I request Dr. Shailia CH to present the memento to Dr. P. Rajan at the document for Thank you, sir. Thank you, madam. Dr. Suresh Kumar E.K. is a senior consultant and head of the pediatrics department at Aster, Calicut. He has served as a lecturer in the Department of Pediatrics and Neonatal Correspondent. His area of special interest is pediatric pathology, and he has undergone pediatric bronchoscopy training from Institute of Childhood, Chennai and Manipal Hospital, Bangalore. He was the principal investigator of international clinical trial on alpha-cerebrosis in disease. He is in charge of pediatric asthma clinic, Aster, Calicut. To his credit, he has several publications in national and international journals. Now, it's my pleasure to welcome Dr. Suresh Kumar E.K. for the section.
Good morning, dear friends, colleagues. First of all, I would like to thank our office bearers for giving me this opportunity to talk to you regarding a very important topic as far as a professional is concerned, as far as a medical professional is concerned, not only doctors, nurses, or even anyone who is working in the hospital. An emergency in pediatrics is actually very, very important. So I will be dealing with only very few conditions which are very important for you and us. Okay, so it is basically the summary of few things which can be done in an emergency situation. You may be working in a primary care hospital or a tertiary care or a quaternary care hospital, but the nature of emergencies are almost the same. Because emergency department is the place where you see the patient for the first time in the hospital. Your first point of contact with the patient. For us, the patient can be a small, won't be, older child. So very big range actually. The age group is from neonate to up to 18 years we consider as pediatrics. So it's a very big range. What's the difference from adults? Adults, you need not much worry about the dosage or the amount of pressure you give during resuscitation. This or the endotracheal tube size, you need not worry much. But in pediatrics, as the age is a big range, you have to think about the appropriate size, appropriate dose, appropriate pressure, appropriate values of the normal range All those things you have to think about when you are dealing with a child, when you are dealing with a baby. So only very few, there is to make it short, 4 conditions. I will be giving some detail about it. After that, I will give an overview of other conditions. That's the plan. So anaphylaxis, respiratory distress, convulsions, poisoning. These are the conditions which I will be focusing. The rest of the things I will just go through, and you can ask questions if you want. If you want any clarification, I can ask. So for organizers, you can stop me at any time. If I exceed time, you can ask me to stop. No problem. So I will be giving you a clinical scenario. You are working in a hospital, whether it is a primary care or a tertiary care or a quaternary care hospital, you are working, and a child, 6-year-old boy, is coming to ED. You are to ED with history of rashes after eating crab. And rashes increased rapidly, and it looked like a wheel formation of the body. Child became pale and less responsive, and when you are examining, the child is hypotensive. What's the situation? Can anybody tell? I have already given you the short list of conditions I am talking about. It is anaphylaxis. Okay, that is anaphylaxis. Child, if you don't attend such a situation, child is going to die. And the importance of anaphylaxis, which is the nightmare of any health professional. Why this nightmare? Is it for management, diagnosis? No. Because when you give an injection, a medication, an outside agent, child can go in for anaphylaxis. Unless you manage it properly, child will die. If you manage correctly, child will come out normally. So it is a decision, that fast decision you are making, which decides the fate of child as well as you. Okay, so if you manage properly, you will be appreciated. If you don't manage properly, you will be punished. Okay, it is anaphylaxis. So coming to anaphylaxis, what is anaphylaxis? Anaphylaxis is the sudden reaction, onset of urticaria, angioedema, flushing, pruritus following any antigenic substance outside the body. So it can be immunologic, it can be non-immunologic, it can be idiopathic. You may not be knowing the reason why the child is getting anaphylaxis. It can be suddenly, without any reason, you can get anaphylaxis. After a viral fever, you can get anaphylaxis. Some chemical agents, you can get anaphylaxis. I've seen children getting anaphylaxis even after the coconut, eating coconut, the child coconut milk or coconut containing ice, poison and all. I've seen it. So it can be medicines, it can be food, it can be an insect bite. And when you see such a child who is coming to our ED with rashes rapidly increasing and getting pale, and you should look for the danger signs. What are the danger signs? One is rapid progression of symptoms. Evidence of respiratory distress in a child with anaphylaxis is a danger sign. Stridor, wheezing, dyspnea, and also retractions of the chest, or child is going in for cyanosis, or child is becoming pale, or evidence of poor perfusion. Sometimes they may be complaining of abdominal pain, vomiting, hypotension, collapse. This is a sequence of events which happen when the child deteriorates due to anaphylaxis. How can you diagnose anaphylaxis? There is a criteria to diagnose anaphylaxis. Basically, anaphylaxis is an acute onset of illness, usually in minutes, sometimes it may take hours. And respiratory compromise and reduced BP or associated symptoms. Or if the child, it occurs after exposure of likely antigens, the event occurs after likely antigens, like if it happened after penicillin injection, that's a likely antigen, then it can be anaphylaxis. So there can be involvement of the skin and mucous tissue, and there can be respiratory compromise, reduced BP, or persistent GI symptoms. Or any child with reduced BP after exposure to a non-allergen. If a child is known to have allergy to you can say coconut, and developed a sudden hypotension, you can say it is anaphylaxis, even without any of the above. Most important thing about anaphylaxis is the immediate management. So can anyone tell what is the exact management of anaphylaxis? Clear management? In any condition, life-threatening condition, ABC is most important. Whatever we say, airway, breathing, circulation is very, very important. So when a child is coming to ED, first you check about ABC. What's the next step you do when you find out it is anaphylaxis or if you suspect anaphylaxis? The only medicine which will help immediately is adrenaline. Adrenaline is the life-saving medicine. Even after knowing that adrenaline is a life-saving medicine, people are reluctant to give. Why? People are afraid of adrenaline because we consider adrenaline as a very dangerous drug. But in pediatrics, don't worry, adrenaline associated complications are almost nil. You are giving adrenaline in which route? Not IV. It is intramuscular injection. Initially it was subcutaneous, but now we give it intramuscular. Intramuscular because if you give subcutaneous, the absorption will be slow because of fat there. So intramuscular adrenaline is treatment of choice during that time. Steroids, antihistamine, all those things are actually included in the treatment, but that won't give you an immediate result. It has got its own half-life to act. Okay, so adrenaline. So anaphylaxis means adrenaline. What's the dose of adrenaline? You are giving injection adrenaline in the dose of 1 mg per ml preparation, that is 1000 solution, 0.01 mg per kg, the corresponding to 0.01 ml per kg. Okay, so such a small amount of adrenaline you give intramuscular, that will save the child. Of course, you can think about other medicines such as giving oxygen, continuous oxygen, giving IV fluids, giving antihistamines, steroids, hydrocortisone, all those things you can give, or you can give H1 and H2 antagonists, and all those things you can give. You have got time if you give adrenaline. If you don't give adrenaline, you won't have time to give all those things. So adrenaline is the life-saving medicine. And if you are not getting, if the child is very sick, child is collapsed, you want to intubate the child or ventilate the child, you can proceed that, no problem. Before you get adrenaline, you have to stabilize the child, ABC, and then you give adrenaline. That's the sequence of life. Is it clear? Don't forget, adrenaline is the drug of choice for anaphylaxis. If you think about adrenaline when you see anaphylaxis, then that is done. Then actually the treatment is over. Rest of the things you have got adrenaline, immediately you should give. And I told you, in spite of knowing this, even in developed countries, even in major hospitals, doctors and nurses are reluctant to give adrenaline. They actually delay it somehow, but that delay will actually will cause problems. And another child, it's a 2-year-old boy, brought to ED with sudden onset breathing difficulty. Child was playing with elder brother, and there is no past history of wheezing or respiratory illness. But on examination, air entry is decreased on the right side of the chest. What is your diagnosis? Very simple. Very simple. Child is playing with elder child. Sudden onset breathlessness. Elder brothers usually give something to the child in the mouth. Maybe nuts, maybe some whistle or something. So child can aspirate it, and it is foreign body aspiration. So foreign body might have gone to the main bronchus on the right side. That has caused decreased air entry on side. Very simple. So for this, only history is enough. The child is playing with elder brother, or child was eating nuts. Sometimes they will give, while eating nuts, suddenly child collapsed, child in breathing difficulty and collapsed. This history is very common in pediatrics. In smaller children, usually less than 4 years. That is why we usually say less than 4 years, don't give nuts to the child. Only grinded nuts should be given. So that is why we should be very careful in giving nuts to the child, or anything which is actually solid, and which cannot be easily chewed by these children. Very important, because it is a very significant emergency. And unless you intervene immediately, what's the intervention? What's the intervention? Bronchoscopy. You have to give bronchoscopy, and sometimes they spit out after coughing, but rigid bronchoscopy is the treatment of choice for this. So coming to respiratory distress in children, breathing difficulty. What are the causes of breathing difficulty in children? So what is breathing respiratory distress? The definition is when breathing doesn't match with body's metabolic demand for oxygen with failure of oxygenation or ventilation. That is the definition of respiratory distress. Common causes, respiratory infections are the common causes of breathlessness or respiratory distress in children, especially nowadays after the COVID era. Now children are getting frequent respiratory infections, and we get a lot of breathing difficulty, respiratory distress due to viral respiratory infections, bronchiolitis or other viral pneumonias, and even bacterial pneumonias we get. Another very important reason is bronchial asthma. Bronchial asthma is a very repeated episodes of breathlessness. We get history of repeated episodes of breathlessness. Then pneumothorax, hemothorax, and aspiration and foreign body aspiration and food other liquid aspiration. Foreign body we mentioned already, and due to trauma, due to malignancy, and other non-respiratory illnesses like cardiac disorders, metabolic, renal, hepatic, all those conditions you get respiratory distress. And as we know, unless we manage this respiratory distress properly, child will go in for respiratory failure. And respiratory failure will cause hypotension, all these complications, multi-organ failure, and the child will die. So initial assessment is a very important thing. Initial stabilization, initial assessment, initial stabilization is very important. So we usually mention about pediatric assessment triangle. I think that will be discussed in your BLS classes. And you check airway breathing circulation, and you correct the shock if the child is in shock. All those things are the first steps in initial stabilization. Then you think about other relieving obstruction if there is obstruction. As I said, mentioned, if it is foreign body, unless you take out the foreign body, the respiratory distress will not subside. So specific intervention. If the child is in cardiac tamponade, if the pericardial effusion causing problems, unless you drain it, it will not do. So that is the second stage, specific management of the conditions. If it is bronchial asthma, we have to give nebulizations with the bronchodilators or steroids, then only the child. If it is pneumothorax, you should put a tube and leave the thorax. These are few positions of the child. If the child is in distress, it will give you some clue. For example, if the child is in tripod position, you can say that child can be maybe suffering from epiglottitis, upper airway edema causing distress in the breath. Stiffened position, again, pneumonias or respiratory distress, and torticollis, or some problem with the neck, maybe abscess, something compressing there. So these are a few positions which will give you clue. And pneumothorax is a condition again which causes respiratory distress, and you can interfere immediately and get a good relief after intervention. It is defined as collection of air that is located within the thoracic cage between the visceral and parietal flora. So it is not in the pulmonary parenchyma, lung parenchyma, it's outside lung parenchyma. There is air getting filled there. So if it is actually increasing gradually, then it will cause tension pneumothorax. So that's a very difficult situation. Unless you drain it, child is going for respiratory failure and mortality can happen. So there are different definitions for the size of pneumothorax, when to intervene pneumothorax. Any pneumothorax, any child with pneumothorax causing breathing difficulty, distress to the child, you have to intervene. You have to take the air out of the pleural cavity. So that procedure will be life-saving. So this is an X-ray of pneumothorax child, and you can see the image where the air is filled. This is the place where the air is filled. Then will be compressed. and that will cause pain as well as distress to the child. So needle thoracostomy is the measure to reduce it. So if you are in emergency department or if you are outside, even outside the hospital, you can actually just put a needle and relieve it to save the child. You need not have all the system. From when if you take to the hospital, we can get all these intercostal tube drainage, vacuum drainage, and all those things you can do from the hospital. But in emergency situation, you can just put a needle either in the fifth intercostal space in the mid-axillary line, or in the second space in the intercostal space in the mid-clavicular line. Any of these points, we can actually put the needle and see the air coming out. Or you can put an IV cannula and take the stillet out like you are putting in an IV line. You can just put a cannula and you can take the stillet out so that it will not injure the line. And even needle is enough to save the life. There is no, you need not worry about walking the lung and causing further damage, because we are at that time, our aim is to take the air out, nothing else. Okay. That is to save the child. And other very important condition is asthma. And asthma is a very common condition. You may be facing asthma, children with asthma frequently. Management is actually simple. Unless the child is in severe status asthmaticus, they usually respond to oxygen, nebulization, and medicines like steroids. Usually in OP in children above 6 years, we give nebulization. We can actually measure the lung capacity and all, if possible. Otherwise, give nebulization with what are the medicines which can be used for nebulization? Salbutamol, we give salbutamol or levosalbutamol or ipratropium or budesonide. These are the medicines which we can use for nebulization from the emergency department. And along with that, you can give oral prednisolone. Even if you are there in the hospital, you are waiting for the doctor to come, you can actually start nebulization. You start nebulization, I know. And you can give a dose of steroids also. Because diagnosis of asthma is not very difficult. They will give you history of repeated episodes of or seasonal episodes of exacerbation of respiratory symptoms. So the correct parents will also tell that, doctor, this is asthma, because they know how the pattern of the symptoms in the child. So they will tell you that it is asthma. Give nebulization. They will tell you, ask you to give nebulization. And you can give 1 dose of prednisolone also, steroid also. And when the doctor comes, doctor can take over and comfortably continue the management. So each age group, it is different. Small children less than 5 years, we should be more careful. We should be monitoring the child. And very small kids, usually we don't say that it's asthma, because about less than 3 years, always think about other diagnoses. It can be foreign body, it can be pneumonia, it can be bronchiolitis, things like that. So even if you are giving nebulization, you should monitor the child closely in the hospital. If the child is deteriorating, the child should be transferred to ICU. And from ICU, we should monitor for development of respiratory failure. And there are many medicines which we can give from ICU. We give, other than nebulization, we can give magnesium sulfate, terbutaline, we can give injection terbutaline, we can give. There are a lot of other medicines, but need not worry about it. But the most important thing is to stabilize the child. Check that oxygenation is adequate, and the most important thing is always give nebulization with oxygen if the child is in significant distress. Mild bronchial asthma exacerbation, okay, but when they are coming to emergency department, always give nebulization with oxygen. That is the most important thing. Otherwise, the child may develop more hypoxia or other complications. Okay. Another very important condition is status epilepticus, seizures. That is another very common presentation in our emergency department. And you may get past history of seizures. The child is already getting seizures. In the past, parents won't be that much worried. They will tell you that child is getting 1 more seizures. Please manage. But if it is for the first time, parents will be panicked. Okay, parents will panic. But we need not panic. Okay, because seizures as such usually don't cause much problems. What causes problems is aspiration during seizures. So most important thing probably will be positioning when the child develops seizures. So we should avoid aspiration by proper positioning of the child and airway. If the airway is patent, the circulation is all right. If the breathing is adequate, you need not worry much about it. So usually, previously we used to say if the seizure convulsions is lasting for more than 30 minutes, it is status epileptic. That's a previous definition. But now it is changed. Even after 5 minutes of seizures, we say that it is status epilepticus. Why? Because even after unless you manage in 5 minutes, there is a chance of more affecting brain. So that will cause long-term problems. So theoretically, the old definition, 30 minutes, okay. For practical purposes, the definition is now changed to seizures lasting for more than 5 minutes or multiple seizures with not regaining consciousness in between the episodes. That's a new definition of status epilepticus. So it can be convulsive or non-convulsive. Convulsive, you can witness and you can see the child is convulsive. But sometimes if you monitor the child with EEG, you can see the convulsive changes or the EEG changes of seizures, but the child may not be seizing. So that also should be managed. But it is not possible to do that in our emergency department. You need to worry about convulsive status only, convulsions with EMERGENCIES. So of course, in such situations, our main aim is to secure an IV line for medications. If you are not getting IV line, child is convulsing, airway breathing you are not seeing. You can give actually intra-osseous also. You can give all the medicines which can be given IV can be given intra-osseous also. There is no harm. So intra-osseous medicines like lorazepam you can, and there are other methods also to deliver. Because if the child is at home getting seizures, parents know about it. They were on anticonvulsant medications. We usually advise them to give intranasal midazolam. There is a midazolam spray, nasal spray, which can be used. Usually in emergency department, we start on IV line, but you may not be getting IV line. So you can give intranasal midazolam preparation or rectal diazepam or buccal midazolam. These are other preparations which can be used for convulsions. Status epilepticus. If you are not able to secure IV line in your emergency department, same thing you can use. And if the seizure is controlled less than 5, you need not hurriedly give anticonvulsants. Seizure controlled within 3 or 4 minutes, but child is otherwise okay. Child is regaining consciousness, you need not worry about it. And usually, febrile seizures are the commonest. Febrile seizures, fever-associated seizures, usually occurs from 3 months to 5 years of age. That's a common age group where you get febrile seizures. That is due to sudden peaking of fever, child develops seizures. But usual thing is it usually lasts for less than 5 minutes. It subsides within 5 minutes. But rarely it goes beyond 10 minutes or 15 minutes. Then we say that it is a typical febrile seizures. That has to be managed. Less than 5 minutes, fever subsided, seizure subsided, high-grade fever, you need to control the fever. You can give other supportive care. You need not worry about anticonvulsants in such situation. But if a child is coming with fever-associated seizures after 6 years of age and below 3 months of age, these situations you should not say that it is febrile seizures. It is a fever-associated seizures, but the cause of seizures may be meningitis or something else. So mentioned about it, seizures, management of seizures. You can manage with IV diazepam or IV midazolam or IV lorazepam or all these medicines. And if it's not getting controlled, you can give IV levetiracetam or midazolam infusion or those things. But when you are doing that, you should think about there can be some reason for the seizures. So you have to think about the other metabolic abnormalities which cause seizures or things like that. You have to rule out hypoglycemia, hypocalcemia. For that, you can actually draw a blood when you are doing all these things. And for investigations, if there is hypoglycemia, you have to correct with sugar. If it is hypocalcemia, you have to give IV calcium. If it is hypomagnesemia, you can give magnesium. All those things. If there is fever, you have to give tepid sponging or rectal paracetamol and control the fever. or if there is trauma or anything, you have to support the child or correct the reason for getting seizures. So usually in home-based or primary care-based treatment, first line it is always better to give intranasal midazolam if available. Intranasal diazepam is also recommended, but it's not available in our place. For rectal diazepam, we can actually use the available injection diazepam as rectal also. Some people use it, but better will be intranasal midazolam or buccal midazolam or IM. Another child, another history. A 3-year-old boy brought to emergency department with the history of accidental intake of kerosene. Child vomited 2 times. Given stomach wash from nearby hospital. And the child developed distress after that. What happened here? Kerosene is a corrosive material. It's a very dangerous thing. But if you drink kerosene, usually won't happen anything. But if you aspirate it, even a drop can cause death. Okay. If you aspirate it through stomach, usually it causes some irritation. But what happens in children is it actually causes damage to the lung parenchyma. It causes lung injury and child develops distress. Usually what happens is when the child takes kerosene, parents make them to vomit. So when vomiting, the child will aspirate the kerosene. The kerosene will change the route to lung. Okay. When you do stomach wash also, the same thing happens. It goes to lung sometimes, aspirate, vomits, aspirate. So if the child has consumed kerosene, don't disturb the child. Take the emergency department. Try not to irritate the child so that we avoid vomiting. Don't use stomach wash for children. Kerosene or any such materials, a paint thinner, turpentine, all those things. Actually, these are all hydrocarbons, which if they aspirate it, when it goes to lung, it will cause problem. If it remains in stomach, usually won't cause any damage. So, supportive care, take the child to ICU, don't disturb the child, for comfortable manner. Coming to poisoning. Poisoning is also a very common thing in pediatrics because children usually experiment. When they see new things, they try. When they see some tablet on the floor, if you give them tablet, they won't take. But if they see a tablet on the floor, they will definitely use it. That happens commonly in children. So that is why we usually get children who come to emergency department with drowsiness for unknown reason. Child was very actively playing, but child became drowsy suddenly and then brought to observe for 2 or 3 days. We usually did not get any clue. Parents will say, he's perfect, gentle boy, he will not take any medicines, anything. Unless we give, he will not take anything. That is the history they usually tell. But children are always, don't believe them, they will take. Definitely take. That is the experimental nature of any child. So we should consider poisoning in any child who is coming with unexplained illness of sudden onset. You cannot, if you are not able to pinpoint the reason, think about poison. And if there is evidence of taking, if it is observed the child is taking, there is no confusion. If you see an empty bottle near the child, you think that child has consumed it. And we should know the maximum dose of it, how much child might have consumed. For example, if you give paracetamol, the dosage is very important. You should calculate the dose. If the child has taken more than 100 mg per kg of paracetamol, that's a toxic dose. So if the child has taken only 50 mg per kg per dose, then you need not worry about it. Above 100 mg per kg, we have to give antidote, we have to observe the child in ICU, monitor the child. So dosage, just maximum dose child might have taken. Then time since the dose. When was the child, when you expect the child might have taken the dose, and how the child is taken. Usually orally, there's no confusion regarding that. History of how, and before presentation, whether the child had any other comorbidity, any drug allergy history, all those things. And you can actually check the toxidrome. Toxidrome is the symptoms which the child develop after the intake of such a particular. If the child is, after taking medicine, if the child is drowsiness, showing drowsiness, then you can say something sedative child might have taken. you can ask the parents whether anyone in the family is taking any psychiatric medicine or anticonvulsant or and even diabetic medicines, hypoglycemics, all those things you can take medicine. You can ask the father or mother to come with the list of drugs which are there in home, that you can ask. The poisoning management is decreased exposure. That is when the child is exposed to something like if the child is exposed to, we can say, organophosphorus. You can clean the child, remove the things things around the child, and you can reduce exposure. And look for ABC or airway breathing circulation, and monitor the child. Some situations you have to do gastric. Most of situations you have to do gastric lavage to remove the toxins, except in hydrocarbons. We mentioned about corrosives. All those corrosives and hydrocarbons don't do stomach wash. Other situations you can do stomach wash. And activated charcoal you can give to reduce the amount of toxin in the stomach. And cathartics, bowel irrigation. And sometimes people used to do surgery even for this, because if the child had consumed cocaine or morphine in a huge amount, usually happens in adolescence, then you can even do a surgery and remove tablets from the stomach. This is also being done to save the child. Then increased elimination by diuresis, dialysis, charcoal hemoperfusion, hemofiltration. These are the methods. Exchange transfusion. The already toxin which reached the blood system can be removed by these methods. And specific treatments. There are antidotes for some of the medicines. For example, if it is a diazepam or benzodiazepines, flumazenil is the antidote. You can give that. Opiates, if they take naloxone is the antidote. You can give. That will save the child. Paracetamol, N-acetylcysteine is the antidote. Iron, if there is iron overload, you have to give desperazole. Tricyclic antidepressants, you give sodium bicarbonate. These are the antidotes which you can use to reduce the toxin levels. Corrosive liquid ingestion, we mentioned about corrosive. Like that, many other corrosives are there. And the alkalis cause more damage than acids, and the liquids are cause more stars than solids, liquid type of corrosives. And battery is another thing, battery ingestion. This battery will actually leak from the esophagus and actually damage the esophagus and rupture it. So that is why even in intestine, it reaches the intestine. If you see a battery, it has to be removed immediately because that will cause perforation. Other foreign bodies sometimes from the intestine it will pass through. Okay, if it is a nut, if it is a small, even keychain, children have swallowed. So these things can pass through the stool. But battery, you should not wait to pass through the stool. It has to be removed. So, stomach washing, corrosive ingestion, and neutralization is also not recommended. No intervention is our invasive interventions required during that time. And long-term scarring is also common with corrosives. These are the things which I would like to, I thought I will mention. Is the time over? Okay, no problem. I just mentioned about few conditions. One is shock and dehydration. There are different types of shock. How will you manage shock? What is the common cause of shock? It is hypovolemic shock. Okay. Children with diarrhea come with shock. Nowadays, it is not very common. When we were doing post-graduation, we used to see a lot of children coming with severe diarrhea, dehydration, and shock. So what's the main problem during that time? To get an IV line. Get an IV line. So now you know, even if you don't get IV line, you are in a situation where IV line is not, no experts to get IV line. Even then you can put, what you can do? You can do marrow. Through marrow, you can give fluids. Okay, with bone marrow needle, you can just and inject fluids. So that is if that's a situation. But in diarrhea, most of the time, child will be stable. Not all children need bone marrow infusion of fluids. Only if the child is in shock. Okay. Otherwise, you can give NG2 and give fluids if the child is dehydrated without shock. If there is no dehydration, no need for IV fluids. Okay. Then other emergencies, infectious. There are other causes of shocks also. Septic shock is there, cardiogenic shock. Each condition requires different types of management. For example, cardiogenic shock, you have to give dobutamine or dopamine all those things. You cannot give huge amount of fluid in cardiogenic shock. Septic shock, you have to give fluids and you have to do iron drops also along with that. So different types of shocks should be managed differently. Infectious disease emergencies. So during COVID time, you might have seen a lot of emergencies related to COVID. Sudden onset of breathing difficulty, childish or adult, even adults. Adults used to get more common. Children with the COVID complications were extremely rare. I think we got only 4 or 5 children in ICU during that time. Only 1 child required ECMO and other high-end care. Otherwise, COVID in children didn't do much. So respiratory infectious disease emergencies are there. And most of the time it will be respiratory emergencies. We already discussed about it. And other infections, other emergencies also happen, like some infections cause myocarditis, so multi-system involvement. Then bleeding is another emergency, GI bleeding. The commonest complication for bleeding, or the commonest cause of bleeding related complication is GI bleeding, hematemesis, vomiting of blood, going in for shock. So we have to control the bleeding. I think that already mentioned in the previous talk. Cardiac things like arrhythmias. Due to rhythm change in the heart, suddenly the heart activity stops and child, unless you intervene, they will go in for failure and death. So that's another emergency. But in children, there is one more condition which is reasonably common, that is myocarditis. Myocarditis is a condition which develops after certain viral infections. So myocarditis usually happens in small children with viral infection, but it is not very common. That is another emergency and usually managed by cardiologists, pediatric cardiologists. Nervous system emergencies other than seizures. For example, if a child is coming with sudden paralysis, Guillain-Barré syndrome, they develop respiratory muscle paralysis and unable to breathe. So intervention like ABC will help you. Airway and breathing protection will help you. Bag and mask ventilation will help. The renal, hepatic, metabolic, endocrine complications. All these emergency situations can happen in our. They can come to emergency department. And immunological complication. This is one condition which after COVID children come to hospital. Multi-system inflammatory syndrome, MISC. But usually they come with minor symptoms or they present with, we can say, mild to moderate symptoms. Severe symptoms causing shock is extremely rare, but you can get. Macrophage activation syndrome is another condition. Children present with emergency department, a child on rheumatological management. They suddenly develop multi-organ failure. The macrophage activation, that's another emergency. Again, it has to be managed depending on the situation, like if the child is in shock, to manage. Snake bite. Snake bite is another emergency which you face in emergency department. There are different, it is a very common thing actually previously, but now it is not that common. We have got around 300 or more species of snakes in India, out of which only 50 or 60 is poisonous. So poisonous snake bites are not very common, but snake bites are common. And if the child comes to our emergency department, we should monitor the child. Usually they won't come with the envenomation most of the time. Only very rarely they come with envenomation. But we will be in trouble because we will have to observe the child for signs of envenomation. If the child is developing in any. So if the child comes with snake bite, you should observe the child. And what's the test we should do? Whole blood clotting time. Whole blood clotting time. Whole blood clotting time means 20 minutes you are keeping the sample. If the blood clots in 20 minutes, within 20 minutes, normal. But you have to repeat hourly for 3 hours and 6 hourly for next 24 hours. Till that time, child has to be observed in the hospital. Okay. If all these values are normal, less than 20, that means child is unlikely to have hematological toxins. Meantime, you should look for neurological toxin signs. Like you should look for dose with the child is developing doses, breathing difficulty, or things like that. And you should give anti-venom for the treatment. ABC is important in like any other situation. ABC is important. Anti-venom usually give 10 vials is the usual dose, whether in pediatric or adult. Because the theory is anti-venom is given to neutralize the toxins or the snake venom. To neutralize the venom, you have to give 10 vials of, at least 10 vials of antivenom, except in saw-scaled viper, where only 6 vials are needed. So it depends on the situation. You may have to give even more than that, even up to 25 vials we can give. An animal bite, that's another common thing. Dog bite is a very common thing. Nowadays it is actually more common. Dog bite is very common, and you should insist on what? Anti-rabies serum or immunoglobulin and vaccine. Okay, both immunoglobulin and vaccine should be needed in children coming with animal bite to our emergency department. Only very minor scratches need on vaccines. Otherwise, all lacerated wounds require immunoglobulin or serum along with vaccines. And transport is another situation where child transport I'm not going to detail. And the communication is another very important thing. Is most of the confusions occur because you might have heard people attacking doctors and nurses from the emergency department. So communication is also very important. You should call them, counsel them, tell them the details, tell them what you are doing, or you should enter somebody to tell them regarding being there. So this is in a nutshell about emergency visits. Hope I didn't bore you by giving you the long lecture. If you have any doubts, you can ask. And another point I would like to mention is not related to this topic. What's the next pandemic? Next pandemic is antimicrobial resistance. So we will be focusing on antimicrobial resistance from here after. So using antibiotics, think thrice, 3 times before starting antibiotic. So when you see an antibiotic is inadvertently given, raise alarm, discuss with the consultant, openly tell. Now, next thing is be a barrier for prevention of antimicrobial resistance. With that words, I conclude. Thank you very much.
Please get your emergency handbook. Thank you. Now I invite Professor Ishais to present a memento to Dr. Suresh Kumar Ise as a second. Thank you, sir. Thank you, madam. Dr. Satya TP, Assistant Professor, Government College of Nursing, Kozhikode, completed her PG and PG in Pediatric Nursing from Government College of Nursing, Kozhikode. She has completed her PhD from RGHS and National Consortium, Bangalore. Madam has scored more than 30 years of teaching experience and various publications in national and international journals in the grades. She is both postgraduate and PhD grade. She had been a resource person for various workshops and seminars. It's my honor to welcome Dr. Satya TP to deliver the session on nursing management of neonates and children after surgery.
Good afternoon all. First of all, I would like to extend my sincere thanks to Dr. Asma Bibi and the entire organizing team for giving me an opportunity to talk on such an important session. And I feel a little bit nostalgic because 12 years back I was here where I learned many of the things as a teacher. So again, I think many of the audience are students of this institution. Okay, so we will start with this is Institute of Maternal and Child Health, Koഴിക്കോട് popularly known as EMERGENCIES, where a huge number of deliveries are taking place in a year, and we are getting both normal and abnormal babies with the many considered disorders. So we are lucky to teach the students or anybody with the practical experience itself. So approximately 15% of infants that need hospital care have a surgical diagnosis, and many more develop surgical problems during their hospital stay. Nursing care in pre- and post-operative period plays an important role in management and outcome of a surgical child, more so when one is dealing with a neonate. Post-operative care is the care given to the children after an operation and before being discharged from the hospital. There can also be post-operative guidelines given for the recovery time at home. So before caring these children, we have to keep in mind certain principles. So it is based on surgery-related differences between children and adults. And the first and most important principle is the metabolic rate of the infant and young in children that is proportionately much higher than that of the adult. They are growing and need more nutrients or frequent feeding. The second principle is that the body tissues of the child heal quickly due to the rapid rate of metabolism and growth, so that there will not be so much days in the hospital after the surgery compared to adults. And the third principle is that the child usually need proportionately less analgesics in comparison to adult to obtain desired comfort level after the surgical procedures. So we should be very careful while administering the analgesics to the children. And the next principle is his or her general condition may fluctuate very rapidly, almost without giving even a single warning sign. So we should keep continuous monitoring of these babies in the post-operative period. And abnormal fluid loss is more fatal in infants and young children, as you all know, as compared to adults. So fluid intake and output must be estimated very cautiously, especially in newborn and old. We have to weigh the pampers. That's the only method in sometimes to measure the output. We will weigh the dry pampers, standard dry pampers. Then the wet pampers, when changing, we will weigh, and the difference in gram that will be equal to ml of urine. That is the way we are calculating the output in a baby who is on pamper without any cavities. And age of the child should be considered for planning pre- and post-operative care. We know different categories of children are there: newborn, infant, toddler, preschooler. So while planning all these things, we have to keep in mind which age group of the child I am going to care for. So these are the important principles that every nurse has to keep in mind while giving care to the patients after surgery, children after surgery. And the important purposes of this post-operative management include to enable a faster and successful recovery of the baby. The next purpose is to reduce the post-operative mortality at all. Sudden complications or sudden problems, fatal outcome may happen even within minutes if you are not properly observing or monitoring the baby. Then to reduce the length of the hospital stay, then provide quality care services, and also to reduce the hospital and patient costs during the post-operative period. These are the important purposes of giving post-operative care. And nursing management in the post-operative recovery, we will see. It is the immediate post-operative period where the baby is cared for after surgery, and the theatre team should formally hand over the care of the patient to the recovery staff. The information provided should include name of the baby, age of the baby, surgical procedure done, then medical history, allergies of the baby if any daughter, then analgesics and anesthetics already received by the baby, then regarding the fluid is what fluid is going on, when it is started, and the blood loss if there is any, then regarding the urine output of the baby, whether the baby passed urine after the surgery, and any surgical or anesthetic problem which is existing or expected to occur in the post-operative period. So all these things should be detailed information should be given by the theatre team to the recovery staff in order to give the continuity of care in this recovery room. And here the recovery staff should monitor patient's vital parameters like temperature, heart rate, respiratory rate, BP, and oxygen saturation, and also the hydration, pain of the baby. All should be monitored in the recovery room and supportive treatment should be given. So the important nursing management aspects in the post-operative recovery room would keep monitoring the vitals. I told this temperature, heart rate, respiratory rate, and BP, oxygen saturation. And this temperature, that should be much cautious about checking the temperature of the baby because most of the time, especially among the neonates, hypothermia is silent killer of your newborns. Hypothermia, if you not intervene properly, may lead to many complications like acidosis, intracranial hemorrhage, or hypoglycemia. Acidosis, many complications may happen. Suppose if you are seeing a baby who is in respiratory distress and who is called rupur or hypothermia, which aspect we will take care of first. Baby is in respiratory distress, you notice that baby is in respiratory distress. That means the rate may be high, there may be abnormal sounds and all, saturation will be low. And also same time we are noticing that the temperature of the baby also is very low. So which thing we will take care first? Which one you will give the priority? Hypothermia, because this hypothermia in newborn, we know there is no heat generation as an adult. There is no shivering mechanism. In newborn, the only way to generate heat is brown adipose tissue metabolism, which is fat tissue seen in the scapula, subscapular area, axilla, everywhere. So this brown adipose tissue should be metabolized to generate heat in this newborn. And if a baby is in respiratory distress, you are not minding this temperature, hypothermia, you are giving oxygen. You are attending the oxygen need of the baby, what will happen? Whatever oxygen you are giving will be utilized for the metabolism of brown adipose tissue. It will not be used for giving to the vital organs. So, if you are giving the oxygen without taking care of the temperature, no use at all. All this oxygen will be utilized for the heat generation purpose by the brown adipose tissue metabolism. So first of all, you have to manage the temperature, then only you will give the oxygen, then only there will be any effect, successful outcome. That is the thing that you have to keep in mind, that especially in NICU and all, hypothermia is considered as the silent killer among these newborn. But many of these are neglected, and in the how we will check the temperature of a newborn? What is the easy method to check? What is normal temperature of newborn? 36.52. You don't know? 36.52. 37.5. That is the normal temperature considered for newborn. Suppose if it is below 36.5 and between 36 to 36.5, it is not considered as hypothermia. It is a warning period, which is known as cold stress. If you are not intervening in this period, the baby may develop hypothermia, as we mentioned earlier. So this cold stress you can easily identify by checking the baby, touching the baby. In normothermia, the baby's temperature will be, baby's skin will be warm in the abdomen or in the extremities. Everywhere the baby skin temperature will be, or you will feel warm to touch. Then you can assume that the baby's temperature is normal. That is the easy method to assess clinically the temperature of the baby. By using the dorsum of your hand, you can just assess the skin, whether it is warm or cold. I told, if the abdomen and periphery both are warm to touch, no need to worry, the baby is in normothermic condition. And if while you are touching, the abdomen is warm, but the periphery is cold to touch, that is the condition that we mentioned as cold stress. And this is a transition stage where the baby can develop hypothermia if not properly intervening. That stage itself, you have to take the measures in order to raise the temperature. Sometimes by mummifying the baby, or covering with blankets, or you can just use keep the baby under light. And in severe hypothermia, you have to keep the baby under radiant warmer itself in order to suddenly raise the body temperature. So that is keep monitoring vitals, especially temperature. Then maintain intake and output chart. Then assessment of the surgical site. You have to check the surgical site for any oozing or whether the dressing is wet. then assessment of the surgical site at all, and also there may be some drains near the incision site in order to drain all the secretions, which may collect there if it is not drained properly. That will interfere with the proper wound healing. That also should be watched for while receiving the baby, and also you have to take or adopt measures to reduce the pain the baby is suffering from. Definitely there will be orders, cost of orders of analgesics, and if in the case of major surgery, most of the time there will be order for pethidine or phenergan, and this pethidine usually the dose usually for children is the same as the weight of the child, and phenergan half of the weight of the child. That is the dose we are getting usually order. And after that, there are many other ways to keep analgesia in children. Most of the time, we are giving IV paracetamol or paracetamol suppository or Jonax suppository. Whatever may be ordered, you can administer in order to relieve the pain of the baby. There is no need the baby to be suffered from pain. And there are certain general instructions in postoperative care. These are applicable to all patients, especially neonates. They should be a part of daily routine care in the surgical wards. And regarding the NPO, first of all, we will discuss about the NPO. And it is one of the most important, mostly encountered challenge in the postoperative ward of the children, because keeping NPO, keeping the baby on NPO is very much challenging. Baby will cry, mother will be in panic, she will be anxious, and sometimes she may be giving oral without showing the healthcare members. That will cause definitely problems, because the baby will be under anesthesia. That will cause aspiration and will invite many complications. So keeping the baby on NPO is a challenging situation. So when we have to break the NPO, usually when the gag reflex returns, you have to break the NPO. And after abdominal surgeries and all, break NPO once the bowel sounds are back. You have to check for the bowel sounds, or when the baby passes flatus, you can start orals or as per the physician order. And infants with the non-bilious aspirate, break NPO only when the aspirate is less than 15 ml. That is, the surgery is involving the upper GIT. Then only there will be non-bilious drainage. So in these cases, when the drainage becomes less than 15 ml per hour, you can stop the per day. Less than 15 ml per day, you can break the NPO. And infants with the bilious aspirate, do not break NPO till further order. Then regarding the fluid management, the postoperative ward, that is also an important area. Postoperative fluid management among children. In the first principle itself, we have seen that it is very easy to develop hypovolemia or dehydration, and same as hypervolemia also, or pulmonary edema also may develop in children very easily compared to adults due to their physiological peculiarity. So we should be very cautious while administering the fluid in children during this postoperative period. And it is done in mainly 3 phases. Fluid management postoperative period is mainly done in 3 phases. First phase is maintenance fluid replacement. Second one, replacement of pre-existing deficits, and the replacement of ongoing losses. There will be many drainage tubes and all. So according to the output from the drainage RTA, right to aspiration, you have to infuse the same amount of ringer lactate. Usually we are giving in the water ringer lactate equal amount of NG to aspiration if there is more than 100 ml. So this is the 3 phases. These are 3 phases where we are instituting fluid management in the postoperative period. And regarding the maintenance requirement of fluid requirement of children, you may all may be familiar with the formula, Holiday and Saga formula. You know the formula? Why you are talking in between? Any problem? Anything? Okay. So maintenance requirement, the main formula we are following is Holiday and Saga formula. What is this formula says? Not only in surgical wards, even in the medical wards also we are following this formula in order to calculate and give fluid for the children. That's up to 10 kg, 0 to 10 kg. The fluid requirement is 100 ml per kg. Suppose the baby's weight is 8 kg. What will be the fluid requirement according to this formula? Baby's weight is 8 kg. 800, 8 kg and 800 ml fluid will be required per 24 hours. So this is 4 ml per kg per hour, approximately 4 ml per kg per hour. And next, after 10 kg, if the baby's weight is more than 10 kg, for each 1 kg extra excess, we have to give 50 ml per kg. So up to 10 kg, we will be giving 1000 ml. So suppose the baby's weight is 15 kg, how much fluid will be needed? Up to 10 kg, 100 ml per kg means that will come 1 liter, 1000 ml. The excess 5 kg requirement 50 ml per kg. So 5 into 50, 250. So 1250 will be the required fluid, maintenance fluid requirement for a child who is weighing 15 kg. That is equal to this 4 ml per kg per hour plus 2 ml again. 6 ml per kg you have to give. If it is through the infusion pump, you have to give 6 ml per kg per hour. That will be approximately equal to this 10 to 20 kg body weight baby's fluid requirement. And after 20 kg, if the baby's weight is more than 20, for each 1 kg extra, you have to give 20 ml per kg. Okay, so 20 kg calculation 1500. Up to 10 kg, 100 ml per kg. Then up to 20 kg, 10 kg 100 ml per kg, extra 10 kg 50 ml per kg. So that will come 500, 50 into 10, 500. So 20 kg 1500 ml order in the fluid. That's extra kg 20 ml extra add. 21 kg weight 1500 plus 20. That is 1520 ml. That is the fluid that will be ordered by the physician. Any doubt? If you can check in the case sheet. So you check the baby's weight and you check what is the amount of fluid ordered for this baby. Then you will verify this formula. So that formula is known as Holiday and Sagar formula that is widely used for maintenance fluid requirement calculation. And also this maintenance requirement, we are adding sodium 3 milliequivalents per kg per day. In the postoperative period, in the fluid, we are adding potassium also. Usually in the immediate first or second day, we are not adding potassium for the postoperative child because due to the surgery itself, whenever there is tissue injury, there will be release of the potassium. So serum potassium will be already high. So after 2 or 3 days, if you are establishing that there is good urinary output, then only we are adding potassium. So that is a maintenance fluid requirement calculation. Then regarding the neonatal, in the first neonatal day, the fluid widely used is 10% dextrose. Not only in the first day, first and second day, up to 48 hours, we are using 10% dextrose. After this, the third day onwards, we are giving isolate P, which is considered as the best fluid for giving children. Isolate is rich in electrolytes. That is the difference. So third day onwards, we are giving isolate P. And also sometimes there may be additive of 25% dextrose. That depends on the condition. And the fourth day also, there will be isolate P. And if there is a prolonged postoperative period, or if there is need for keeping the baby prolonged NPO, they may be ordering calcium gluconate too. Then usually the type of fluids used, we have already mentioned, first 2 days of life, that is 48 hours, we are giving 10% dextrose. And in this period, there is no need of more electrolytes. And day 3 onwards, isolate P is the widely used fluid. And it is ideal for children up to weight 12 to 13 kg. This isolate P. And 15 to 20 kg babies, isolate P plus additional sodium. That is the fluid we are giving. Then how we will administer this fluid? If on presentation, if the baby is appearing to be in the dehydration state, you have to administer 10 cc per kg, 10 ml per kg normal saline or ringer lactate. Whenever a baby is noticed to be in a state of dehydration signs of the tachycardia, weak pulse, urine output will be less, the extremities will be cold, baby's conscious level may be altered. So if you are noticing any baby in this postoperative period as like this, having dehydration, the amount of fluid that you have to administer is 10 cc per or 10 ml per kg as an IV bolus. That either you can use normal saline or ringer lactate. Then potassium to be, as I mentioned earlier, potassium to be added from the day 3 onwards if there is adequate urine output. And if the baby is having any third space losses, especially if the baby is under warmer or phototherapy, along with the calculated fluid, we have to administer 10% extra. And also if there is losses through the GIT at all in the NPO period, in the immediate post-op period, the baby will be on right tube aspiration, continuous right tube aspiration. So if the drainage calculated is coming more than 100 ml, you have to rehydrate the baby with the equal amount of ringer lactate. That is the practice in our ward. We are growing 100 ml or more than 100 ml output. NG tube kuda kanuvanenkil 3 ml ringer lactate should be infused. That is the third phase management at all. Replacement of the ongoing losses. 3 phases we have mentioned now. Maintenance fluid requirement, then regaining the already existing loss and replacement of the ongoing loss. These are the 3 phases in fluid management in the postoperative period. So if there is extra amount of drainage is observed through this NG tube, you have to administer this much amount, equal amount of ringer lactate solution. This is especially important in neonates with the intestinal obstruction, both the pre and post-operative period. In intestinal obstruction, there will be NG tube aspiration definitely. In the pre-operative period itself, there will be NG tube. In order to keep the abdomen free of gas and fluids. So there is increased fluid requirement in case of LBW babies. Then if the baby is under phototherapy, if the baby is under radiant warmer, or if there is polyuric renal failure. And also, there is decreased fluid requirement if the baby is having cerebral edema or inappropriate ADH secretion, or if the baby is in congestive cardiac failure, or if there is oliguric renal failure, you will notice. In those cases, we should be very cautious while administering this fluid. Then other general instructions in the postoperative ward include, you have to change the bed sheets daily or whenever it is wet. Also, you can use Macintosh beneath the sheet and check whether IV line is secured properly. In any evidence of thrombophlebitis, or if IV line is out of order, or it is doubtful about its placement, or if there is any redness, swelling, or if the IV dressing is or splint is wet, then in all these situations, you have to immediately remove the line and secure another one. And in babies receiving IV fluid, change the Bural set after every 48 hours. Definitely, you have to mention the date while changing the IV set. And all drainage bags should be emptied at least once daily, preferably in the morning or more frequently as per the instructions. And also, the amount and nature of the drainage should be documented well. Because I know if the drainage is more than 100 ml, you have to administer equal amount of ringer lactate. Otherwise, the baby will develop dehydration and also electrolyte imbalances. And also, nebulization to be given to all operated patients, and it is a must for the sick neonates. Usually, we are giving nebulization with the normal saline every 6th hourly in the post-op ward. And also, you have to weigh the neonates regularly, at least twice a week, and should be mentioned in the patient record. And mother being the best nurse, involve her actively in the newborn care. And next instruction regarding the per-rectal suppositories. You know, regarding the children, these suppositories have an important place as medication of the baby, and it is need to be inserted by the nursing staff as per the schedule. Never delegate this duty to the relatives. Suppositories to be well lubricated before the insertion. And in some cases like PSARP, it is one of the commonly observed procedure in pediatrics. PSARP means posterior sagittal. That is exposed. PSARP means posterior sagittal anorectoplasty, which is the accepted method of surgery in anorectal malformation. In this case, you should never insert suppository, or you should never take the rectal temperature. Next, regarding the prevention of hypothermia, you have to cover the baby's head with a cap. Use socks for legs, mitten for hands to prevent the heat loss and thereby hypothermia. Change wet linen, splints and dressing immediately. Preterm and high-risk babies should be cared under radiant warmer, as I mentioned earlier, because this hypothermia is the killer among all the babies, not only in surgical babies. And educate all mothers regarding benefits of breastfeeding and offer support and help them to successfully feed their babies. Or simple teaching is not enough in these situations, because these babies undergo surgery will be vulnerable babies. They will be with many tubes. NG tube will be there, oxygen may be there, drainage tube will be there, urinary catheter may be there. So in this situation, it is very difficult for the mother to feed the baby alone. Especially most of the time, the mothers will be priming preterm babies. So in those situations, rather than teaching them, you have to support them. You have to help them how to feed the baby properly, and help them to solve the problems of engorged breast. Because this breast engorgement is a commonly noticed problem in these mothers, because babies will be on NPO immediately after diagnosing, and during the pre-op and post-op period, the baby will be on prolonged NPO. It is not sucking. So there is a high chance of getting breast engorgement. So the measure should be directed towards clearing this engorgement too. The mother may be suffering from severe pain. So warm compress may be helping, or help her to empty the breast frequently during the time of NPO. All these things should be kept in mind in order to start breastfeeding immediately after the NPO is broken. Otherwise, when the baby's NPO is broken, there is no way to give the milk. Mother will be suffering from many problems. So all these things should be anticipated beforehand and should be intervened properly. And teach mothers to express out the milk regularly and keep the breast empty as possible. In our hospital, there is human milk bank. It started, I think, 1 year or 2 year back. So all these NPO, the mothers of these NPO babies, they are going to the breast milk bank and they are donating their milk. But there are certain criteria. All mothers cannot donate blood. They should not receive blood transfusion within 6 months. Their serology should be negative. There should not be any infections for the mother. Then only they will accept those milk. But that is another, especially in babies, NICU, babies in the milk doctors expressed breast milk order. Order milk bank order blood bank order order milk bank keep milk. About 6 months they can store. This is a vigorous process. After taking the breast pump breast eligible mothers pasteurization culture negative label they will keep in the run. So I think I told about 6 months we are keeping the milk there, but 6 months within 1 week itself all the milk will be used up. So many babies are on NPO and they are in need of breast milk. So that's a good way to help the mothers whose babies are on NPO in order to prevent the engorgement. So teach mothers to express out milk regularly and keep the breast empty as possible. And if there is any inverted nipple, teach them to massage it with oil in an effort to bring it out for the effective breastfeeding once the NPO is break. And ensure the mother is getting adequate milk approximately 2 to 3 days in advance. Once there is indication that the baby may be started or feed soon. So NPO break we have to check the mother whether there is adequate milk. In addition to emotional support, prescribe galactose like Perino or Sadaveri powder, etc. for the mother in order to induce breast milk production. Also ensure that mother is getting iron and calcium supplements that should be continued about 3 to 4 months for successful breast milk. Then educate mothers about the importance of proper burping after each feed which will prevent mishap from the aspiration. So these are all the general instructions that we have to keep in mind while giving care to any baby, including newborn in the surgical wards. And now we can see certain specific conditions. I don't think there is enough time to tell about every condition, but some of the common conditions you can see that the do's and don'ts. Esophageal atresia and tracheoesophageal fistula you are familiar with. There are two conditions. One is esophageal atresia. There is the condition where the esophagus fails to develop as a continuous canal. And tracheoesophageal fistula means there is an abnormal connection between trachea and the esophagus. There is failure in the separation of trachea and esophagus in the prenatal period. So in this condition, there are 5 types. First, it is a condition. Among the 5 types, first type only esophageal atresia is there. There is no fistula. You can see in the picture. And in the 5th type also, only one defect. There is only fistula. There is no atresia in the esophagus. And in between, there are 3 types. There is both atresia and fistula. Second type is fistula, upper pulse, esophagus in the upper pulse. Third type is esophagus in the lower pulse, fistula. And the fourth type is upper in the lower, there is connection with the trachea. So these are the 5 types, and there is connection between the esophagus and trachea. So immediately after delivery itself, we will be able to identify whether this baby is having tracheoesophageal fistula. What are the means by which we are identifying? Immediately after swallowing first or second breastfeed, the baby will show excessive frothy saliva and secretions from the nose and mouth, because the esophagus is not complete. There is block. So it will be coming out and baby will show the respiratory distress features. And in those cases, the easy way to confirm or to make sure that there is a fistula, you can insert an NG tube and it will not go. The tube will be met with resistance, it will not go deep. So in those situations, you have to stop the breastfeeding at the sudden and start IV line. And also the baby should be kept in proper position. NG tube should be inserted in order to drain the esophageal secretions. Otherwise, it will go to the trachea through the fistula and may cause chemical pneumonitis and other problem aspiration. So this is a surgery they are doing. In the case of tracheoesophageal fistula, fistula will be removed and will be sutured, and the esophagus part where there is fistula, that part is removed, and there is end-to-end anastomosis. The approach we are doing using is posterior lateral thoracotomy. So in this case, what are the things that you have to take care? What are the do's in the postoperative period of a baby with the tracheoesophageal fistula repair? Baby to be nursed in proper position at all, and that is to prevent the aspiration. Then monitor the vital signs and oxygen saturation. Administer oxygen as per the order. As in any other case, nebulization with the normal saline. Then there should be restraints for the elbow of the child. Otherwise, the NG tube may be removed accidentally. And hourly aspiration of the NG tube contents. And 2-hourly oral suction, both the pre and post-operatively. And regarding the don'ts, don't extend the neck of the baby and insert oral suction catheter more than 5 cm is not indicated. And unnecessary moving or shifting of the baby also should be avoided, because this anastomosis site may be disturbed. And report any respiratory difficulty to the surgeon even after proper suctioning to remove the secretions. And these infants are under constant threat of developing all the respiratory complications. There will be ICD tube. The course drainage tube will be there. So empty the ICD bag once in a day, preferably in the morning, in the presence of resident doctor, if it is there. That also should be done only after clamping the ICD. And also you have to go measured quantity of sterile, normal sterile till the water level mark. There is a proper way of emptying ICD drainage through fan, and the amount should be noticed, documented. And all the nursing activities like bed making should be done by 2 nurses supporting the baby's neck optimally, so as to prevent the undue movement of this anastomotic site. And since the baby is kept on NPO, hydration and nutrition by the parental route, as we mentioned earlier. Postoperative fluid management. And next, another important condition that we are dealing in the practical situation is congenital diaphragmatic hernia, CDH. Rather, it is a medical emergency, and after sterilizing the medical situation, they are taking the baby for surgery. It occurs when the diaphragm fails to close during prenatal period. So that through this defect, the abdominal organs, mainly small intestine or liver or stomach, may be migrate into the chest. If it is the right side, most probably liver will be migrating in the thoracic cavity. So you can see in the picture, all the contents are in the thoracic cavity, giving little space for the lungs to expand. And the lungs will be smaller than expected in this case. It's called pulmonary hypoplasia and will have less developed blood vessels. This causes high blood pressure in the lungs. It is called pulmonary hypertension. And after surgery, what they are doing in surgery in this situation? Liver and the whatever part is going migrated into the thoracic cavity will be reduced back into the abdominal cavity. So in this case, what are the doses? You have to monitor regularly the heart rate, respiratory rate, and SpO2. Insert NG2 and regular NG aspiration. Urinary catheterization. In case sudden deterioration, suspect pneumothorax. And nebulization and physiotherapy, very important in the postoperative period. The next condition, another important condition, upper GI condition, IHPS. You may be familiar with this condition, infantile hypertrophic pyloric stenosis. This is one of the common surgical conditions which cause non-bilious projectile vomiting in children. And it is characterized by enlarged pyloric musculature and gastric outlet obstruction. IHPS typically presents with the progressive projectile non-bilious vomiting, which commences between 2nd and 8th week of age. Before it was termed as congenital hypertrophic pyloric stenosis, but now baby demonstrated this condition immediately after birth, and usually occurs after 2 or 3 weeks. And that's why now the term is infantile hypertrophic pyloric stenosis or IHPS. And babies are here classically described as being emaciated, dehydrated, and you can palpate an olive-shaped mass at the lateral edge of the rectus abdominis in the right upper quadrant of the abdomen. And also there may be peristaltic waves seen progressing across the child's upper abdomen from left to right just before vomiting. These are the typical manifestations that we can see in case of IHPS babies. So in those cases, when the baby is coming, definitely the baby will be in severe dehydration. There may be metabolic alkalosis. There will be thirst, severe thirst. So this condition, they are taking the baby for surgery only after stabilizing the baby. Only after initial stabilization only they are taking the baby for surgery. And the name of the surgery is Ramsden's spideromyotomy. And in this case, after the in the postoperative period, patient started on feeding with a clear fluid usually 4 to 6 hours after surgery, and gradually they are increasing the amount and switch on to breastfeeding on full feeds after 24 hours of surgery. Then while feeding these babies, you should feed the infant very slowly, burp frequently, and position in high Fowler's position in order to prevent aspiration. And also keep the baby on right side to prevent aspiration and promote tolerance of feeds, as there is gravity drainage when we are giving the feed in the upright position. So regarding other abdominal surgeries, mainly for intestinal obstruction, in the postoperative period, you can expect surgical drain near the incision. It is kept to remove the drainage after surgery due to oozing from the side, as the pooling of secretion may reduce the healing process. And there will be IV line connected with the fluids to provide adequate fluids and electrolytes after surgery to meet the metabolic needs, as the child may be on NPO. And NG2 will be there, which is connected to drainage gland. And this will help in drainage and keep the stomach free of fluids, gases, and that will prevent the abdominal distension. It also prevents nausea, vomiting, and aspiration of contents to respiratory tract. It is removed once the peristalsis is resumed and the amount of drainage is minimal. I told when there is drainage more than 100 ml, you have to re-administer the same amount of ringer lactate. That is the practice. The need for pain management. Pain management is essential for early recovery. A child in pain after surgery will be reluctant to perform exercises, or he will be reluctant to cooperate with our procedures. That may result in complications like pulmonary atelectasis, hypostatic pneumonia, phlebitis, etc. It is also essential for early ambulation and recovery. There are different areas in which pain can be assessed. We can observe the baby and assess the pain severity. Pain scales are there. So the physiological signs are easy to interpret, and they include increased BP, pulse, breathing, and surging. And pain control already we have mentioned. The major surgery, there will be order for pethidine or penalcan, especially HS during the night time or SOS. And after that, other simple analgesics like suppositories may be there, IV infusion or IV paracetamol suppositories or Xanax suppositories. Then other non-pharmacological measures also you can adopt for pain relief. Then if there is stoma, the care of the stoma also should be taken care of. Maybe colostomy or ureterostomy. And also psychological support to the parents. That's also very much important, because we know when a mother is getting baby with such anomalies or congenital anomalies, or the baby is undergoing many surgeries, the mother will be in stress. So many of the time we are seeing the parents, mother sitting in a depressed state. They may not be even looking after the baby. So in these cases, you can intervene by giving proper explanation, and also if needed, counseling can be given to the mother so that she will take care of the baby properly, which will help in easy recovery of the baby. So that's all regarding nursing management of children undergoing surgery. I think it is okay.
Thank you, ma'am, for the session. Only, it is a time to transfer. Now I invite Professor Childs to present the memento to Dr. Sajana GP as a token of our gratitude. Thank you, ma'am. Dr. Abraham has completed MBBS and MS from CNC Bellu and FCH in Pediatric Surgery, Institute of Maternal Childcare, with a law. Dr. Nam worked as a senior consultant, Department of Pediatrics and Neonatal Surgery, Malabar Institute of Medical Science, Kerala, and Most Hospital College in Kerala. He was the Chief Surgical Officer in Department of Pediatric General Surgery, Royal Children's Hospital, Melbourne, Australia. His areas of special interest are pediatric urology and reconstruction, neonatal surgery, minimally invasive surgery, antenatal guidance and counseling, and legal advice for healthcare. He is presently the Chief of Medical Staff and also heads the quality department at the Aster Academy. It's my pleasure to welcome Dr. Abraham to deliver the session on acute abdominal children and neonatal surgical emergencies.
Oh, thank you. Good afternoon, everybody. Lovely time, good lunch. Now is the best time to sleep, right? Yes. So I will try to keep you awake. It is my challenge. So I think you had a talk on medical emergencies in pediatrics and neonates. You had nursing management of a surgical patient. Now we will go a step backwards and see some of the problems surgical problems that can be seen in pediatrics and neonatology. So first of all, let me thank the organizers for having given me this opportunity to share my thoughts with you. The topic given to me is pediatric surgical emergencies, pediatric and neonatal surgical emergencies. Let me start by saying that it took me 3 years to learn this. And I'm supposed to talk to you in about half an hour, which is the next challenge that I have to face. So let's hope we can get somewhere during this next half an hour. Basically, I'm trying to just say a few highlights about some of the pediatric emergencies, neonatal emergencies that you should know. There are many and numerous conditions. It's very difficult to cover the entire thing. So I'll just select some of the common ones which you are likely to see during your common nursing experience. Just to understand the background of your nurses, are you all staff, students, or what are you? All of you are students. Have you had a surgical posting? Pediatric surgical posting? No. Yes. So that means I have got a free field to play around with. So we'll start from there. See, remember, in a child or a baby, you can't ask questions to the child. When did you start vomiting? You can't ask a 3-month-old baby and say, when did you start vomiting? Where is the pain, etc. So you have to go from taking the history from the parents. And that is the biggest challenge that a pediatric surgeon has. And secondly, the symptoms are very important. They are much more important than in adults. So when we talk about symptoms, these are some of the commonest symptoms that occur in a surgical baby, newborn or otherwise. Vomiting, and I will go into some of the details about this in a short while, but basically what you should be looking into is history of vomiting. Abdominal distension, that's very, very important. Is there a distension? Is there no distension? Is the distension soft? Is the distension tense? Pain. Pain is something which you cannot ask, especially the younger baby. You have to learn to elicit the sign of pain. Basically, get the baby to calm down, lie down comfortably, and gently palpate the area to find out the pain. Never go straight to the child, poke your hand in and try to get the history of pain. That baby will start crying, and that's end of story. You will never get anywhere. So get the baby's attention, calm the baby down, start from an area where you don't think there is pain, and gently move to the area which there is pain. Meconium abnormalities is very important, especially in newborns. Just to see if you're awake, how many of you know what meconium is? Hands up if you know what meconium is. No? Meconium is the first motion that the baby passes and lasts for about 24 to 48 hours. This consists of basically, this baby has not been fed so far. So usually this does not contain food particles. It has epithelium which is shed from the intestinal mucosa, amniotic fluid which is swallowed. It has the hair which has been shed from the baby in utero. So it gives you a black colored pasty motion. Once the baby has started feeding, then you find the motion changing from this black color to a milky to a yellowish color, which is what we call milk stools. So meconium history is very important to know whether there is neonatal problems. Urinary symptoms are very important, especially the stream of the baby. A male child should have a forceful stream. It should not be a dribbling stream. It should not be along the side of the thigh of the baby, but in an arc going a little distance. Please note the distance does not matter. This is not an Olympic competition. All you need to make sure is that it is not dribbling and it is not draining along the side of the thigh of the baby. Breathing problems, again, tachypnea, stridor, all these indicate that there is some sort of a respiratory problem. If the baby or the child has been fed, then feeding problems, regurgitation, failure to feed, difficulty in feeding, etc. And very importantly, you have to have look for external malformations of the child. So visual examination is very important. Coming back again, history is very important. So when you take any of these symptoms, you got to go back to the parents and talk about the history. For example, in a child with vomiting, the age of onset is very important. Is it since birth? Is it since 2-3 days? Or what is the duration of the thing? Now, if you take the mother, invariably they'll say, you're all Malayalis? Non-Malayalis here?
Yes.
Because I may slip into Malayalam in between when I talk about patient history, etc. So if you have a problem, please let me know.
We have only Zoom people are attending.
Oh, is it? Oh, I didn't know. So you can have patients, when you take a history, the mother will say, this child has been having vomiting for the last 6 months. Child is 7 months old, but is vomiting for the last 6 months. If you actually go into the history, yes, this child had vomiting over the period of 6 months, but these are all episodic vomitings. It is not continuously full. So you need to differentiate between recent episode and a long-term vomiting. Very important is whether this vomiting was there in the newborn period or did it occur later on. Newborn vomiting has got much more significance, especially if it is bilious. Bilious means it is stained with the color of bile, which is yellowish or greenish yellow. So greenish yellow or yellowish bile stained vomiting has got a greater significance than non-bilious vomiting. Vomiting has to be again differentiated from possetting. Possetting is small amount of vomit that occurs when the child burps. When the gas is expelled, small amount of vomiting occurs as possetting, and that is normally seen in the newborn. It's not a pathognomic feature. Drooling is continuously saliva drooling out of the mouth, especially when you have obstructions to the upper GI tract. Is the vomiting associated with distension or not is again a very crucial history, and also whether it is associated with the constipation, as I will see later. Now, bilious vomiting, if you have, I told you, is a very, very pathological condition and needs to be investigated before we can say this is not a problem. Bilious vomiting in the newborn is usually suggestive of a duodenal level of obstruction, where the ampulla of Vater opens into the duodenum, and that is where you have the bile draining into the GI tract. So vomiting occurring below the second part of the duodenum will be bilious vomiting. And bilious vomiting is suggestive of duodenal atresia. Part of the duodenum is not formed. More importantly, malrotation. And I'll show you what malrotation is in a short while. Intestinal atresia, infections of the bowel where you have necrotizing enterocolitis, Hirschsprung's disease. These are some of the common things in the neonate which has bilious vomiting. Older children, vomiting is usually acquired as compared to congenital in the newborn period. And some of the common ones include intussusceptions, peritonitis, and intestinal obstruction. Now, malrotation, just want to talk to you in a few minutes about it, is a condition which is commonly seen in newborns, and it's important because it can result in very tragic situation if we ignore it. Has anybody had a neonatal postings? Have you seen malrotation? No. Okay. Basically, remember, during embryology, when the child is being formed, after the ovary and the sperm join together and forms a zygote and starts forming the baby, you have the bowel is in a straight form. It is starts at the mouth, ends at the anus, straight tube. Now, if you have a straight tube, you can imagine what the length of the intestine is going to be in an adult, and that is not enough for all the functions of the adult, which GI tract functions, namely absorption, digestion, etc. So you need to increase the length of the bowel, and for that, nature has found a very, very nice method whereby there is what is called rotation of the bowel. Now, I'm not going into the rotation of the bowel, but basically what happens is the straight tube rotates through 360 degrees, increasing the length of the bowel so that it can fit into the same abdominal cavity. And that is called rotation of the bowel. Failure to rotate can occur in some conditions, and that is called malrotation. And that is very important because the diagram on the right side shows the normal rotation. You have the mouth at the top, anus at the bottom. And it used to be a straight tube, which after rotation will now finally have this sort of thing. Stomach on the left side, duodenum on the right side, small bowel completely like a snake, ileocecal junction in the right lower end, and the colon going up and opening into the anus. This is the normal rotation of the gut. When you have this failure of this thing, you get what is called malrotation. And that is seen on the other side, where you can see the stomach is rotated, but the duodenum and the small bowel is not rotated. It remains all on the right side. It is not on the left side. Now, this is very important because this results in two important pathologies. It results in intestinal obstruction, which produces vomiting. And this is an X-ray which shows a duodenal atresia or a malrotation, where you can see the hugely dilated stomach and the proximal duodenum and just gasless. So you have a gasless abdomen. This shows barium. You see the stomach on the left side. The bowel comes to the right, and then it's all on the right side. It's not going back onto the left side. This is again malrotation. In malrotation, what happens is there are what is called these bands over here, which are normally present. These so-called Latz bands result in obstruction to the level of the duodenum, second or third part of duodenum. And so these babies present with severe bilious vomiting in the newborn period. Secondly, they have what is called a very short mesentery, and therefore they can undergo twist on that mesentery. And that is called volvulus. So volvulus and obstruction are two dangerous signs, because if this continues without relieving the obstruction, the entire bowel supply, blood supply can be affected, resulting in gangrene. And the gangrene will extend from the duodenum right up to the transverse colon, which means you're going to lose the entire gut. So malrotation in a child is dangerous because if not treated immediately, can result in total loss of bowel, which is dangerous and fatal. So the treatment of this is dividing these bands and widening the mesentery, which is what you see there in the other picture. Please remember, the malrotation continues to be there. Rotation will not be corrected. You cannot correct the rotation, but the obstruction and the volvulus is prevented. So rotation will still remain as it is. Madam has already talked about many of these things, but I would like to emphasize that post-op period nursing management is very, very crucial. The surgeon can come and do an operation, can do all sorts of things, correct the obstruction, latch bands, mesentery, etc. But the success of the baby depends on how he recovers post-op. And for that, nursing methods are very, very important. And these are some things which you have to remember in children. It is crucial. It may not be so crucial in adults, but in children, it's first and foremost is Riles tube decompression of the upper GI tract. Post-operatively, these babies all go into ileus, paralytic ileus. The abdomen, the bowel stops functioning temporarily, but the stasis occurs due to which the bowel distends. And this distension can result in vomiting. And remember, in a child, vomiting is dangerous because they are not yet learned how to vomit outwards. They lie in bed, vomit, and they aspirate. So in addition to the surgical problem, they develop problems due to aspiration and lung issues. So Riles tube decompression is important. And this is very important, especially because I have heard this many times and I cannot understand. When you go for rounds, they say the NG tube is in place. Riles tube is have 30 ml, 40 ml, but the child vomited 3 times. Now, if the NG tube is normally there and in good position, the child should not vomit. So a child with Riles tube, if he is vomiting, please make sure that it is not blocked, it is not kinked, and it is decompressing and doing the job that it should be doing. Because just saying that Riles tube is there, but vomited is not a good nursing methods. Temperature is very, very important in children. We take it for granted, but temperature is very, very important. Hypothermia in children can cause all sorts of problems, from delayed wound healing, wound sepsis, peritonitis, infection, etc. So we maintaining these children on normal temperature, whether it is very cold outside or very hot outside, maintaining euthermia is important. So make sure that the babies are covered all time. Make sure their warmers are there if they are exposed, etc. Oxygen, of course, depends on if you read it or not, but monitoring the oxygen saturation is very, very crucial. And transferring these babies as early as possible to areas of treatment is crucial. Keeping them late can result in problems. Going on further, non-bilious vomiting is another type of symptom that you have, and that is usually seen in conditions like idiopathic hypertrophic pyloric stenosis or congenital hypertrophic pyloric stenosis, GERD, which is gastroesophageal reflux disease, preduodenal obstructions, and very important, please remember, many of these vomitings can occur in non-surgical conditions like sepsis, etc. So please keep medical conditions also in mind. This is an example of a IHPS where there is hypertrophy of the pyloric muscle. The muscle in the pylorus, which is the terminal part of the stomach, undergoes hypertrophy. Reasons we don't know. And because of that, this causes obstruction, distension of the stomach, stasis in the stomach, vomiting. Because this occurs way before the ampulla vata opening, the vomiting here is non-bilious. So you find a non-bilious vomiting, you have to think of CHPS or IHPS. The diagnosis is very simple. Ultrasound is what we use routinely now. Earlier we used to use barium studies, but ultrasound is much more sensitive, so it gives much better answer. Vomiting associated with abdominal distension and constipation or failure to pass meconium. You need to keep 2 of these conditions in mind in a newborn: Hirschsprung's disease and anorectal malformations. Hirschsprung's disease is absence of ganglion cells in the terminal part of the bowel. That becomes spastic, collapsed, and acts as an obstructing element, and you have intestinal obstruction due to Hirschsprung's disease. Diagnosed by use of plain X-rays and barium studies. You see the bowel on which is grossly distended. This is a newborn bowel, and it's about 10 times what it should normally be, which is suggestive of Hirschsprung's disease. This is a child with an anorectal malformation. Anorectal malformation means basically the anus and the lower part of the rectum is not formed. You can see there is no opening there, it is absent. It's an anorectal malformation, so there is no way in which the bowel can decompress. They present with abdominal distension, failure to pass meconium, vomiting, bilious vomiting, and colicky abdominal pain. Another example of an imperforate anus. Anus is absent. It's a congenital abdomen. Again, some practical points about intestinal obstruction. As I mentioned earlier, Ryle's tube decompression is the most important. The Ryle's tube has to be of adequate size. A tiny Ryle's tube, just for the namesake, is not of much use at all. A proper one, appropriate for the size of the baby, should be used to decompress the stomach and the upper GI tract. Temperature has to be maintained very carefully. Oxygen saturation has to be monitored and supplemented as required, and as and when required. Respiratory distress, especially in the newborn, these are some of the conditions that we normally come across: diaphragmatic hernias, esophageal atresia with or without a fistula, and lobar emphysema, etc. But one thing that you need to know is a condition called pneumothorax in the newborn. This word produces acute onset respiratory distress in the newborn. Babies suddenly become tachypneic. They are indrawing breath. They may be stridor. Oxygen saturation drops, and this is usually due to a small rupture of the lung, some part of the lung, resulting in air leaking from the lung into the pleural cavity. The air is trapped there. With each breath, it keeps increasing, tension mounts, and you have compression of the opposite lung also, resulting in severe respiratory failure. This is life-threatening. Within a few seconds or minutes, the baby can collapse, and that could be the end of the story. So you need to intervene immediately by decompressing this immediately. Just sticking a needle into the chest on that side will decompress the pleural cavity, and then that will give you enough time to put in an intercostal tube and drain the pneumothorax properly. This is an X-ray of a child with a diaphragmatic hernia. I'm not too sure if you can see clearly, but if you look on the left side of the left picture, the left heart is pushed, and there is loops of bowel in the left thorax. So the abdominal contents, which should have been in the abdomen, has shifted up into the chest due to a defect in the diaphragm, causing respiratory compression and problems. This is called diaphragmatic hernia. Another picture, you can see that there are no intestinal gas shadows. The entire gas shadows are in the left thorax. That's a diaphragmatic hernia. Diaphragmatic hernia, important things that nursing point of view is, again, Ryle's tube decompression is extremely crucial, because if that stomach inflates, distends, you can get further and further decompression of the lung. So Ryle's tube decompression of the stomach is very important. Of course, temperature maintenance. The next thing is that these babies should never be given bag and mask ventilation. Why? Because if you do a bag and mask, air goes both into the trachea and to the esophagus. The stomach will fill up, the stomach will distend, and that will result in further distress. These babies, if they have diaphragmatic hernia diagnosed, have to be intubated immediately and ventilated. No bag and mask for them. Esophageal atresia is a condition where part of the esophagus is not formed. It may be with a fistula to the trachea or without a fistula. These are the babies which will present with drooling. Since they have an atresia, the esophagus is not in continuity with the stomach. You will find saliva accumulating in the upper pouch, and this will continuously keep drooling from the side of the mouth, from the sides of the mouth, and also into the trachea. So you need to be sure that you decompress them properly. Here you can see a esophageal atresia with an upper pouch where the esophagus comes to about middle of the chest and stops. Further, there is no further development. Newborns with jaundice, again, is an important. Please remember, jaundice is physiological in many babies. Up to the age of about 2 to 3 weeks, you can get physiological jaundice. But prolonged physiological jaundices can be significant. And if you do have that in your history, please make sure you rule out some of these conditions like biliary atresia, choledochal cyst, etc. Again, There are non-surgical conditions, and sepsis is again a very important one. You can find newborns with jaundice because they are septic. So please keep medical conditions also in. This is an example of a biliary atresia. The liver normally is drained by the right and the left hepatic ducts into the common hepatic duct, common bile duct, and into the gallbladder, from where it drains into the duodenum. But here in this condition of biliary atresia, the part of the apparatus beyond the liver is totally atresia. So there is no drainage of bile from the liver into the duodenum, and they have regurgitation of the bile back into the bloodstream, resulting in physiological, exaggerated pathological jaundice. The importance of this condition is that time is limited. If you wait on them, there is progressively destruction of the liver. 6 weeks of after birth, if you don't drain these, by 6 weeks, if you don't drain them, they have permanent damage and they go in for cirrhosis. So we have a crucial cutoff at about 6 weeks, where you have to make sure you diagnose this, and then it is treated immediately before it reaches a stage where it is bad. Early treatment gives good results. Late treatment ends up in cirrhosis, and you need then the only choice is liver transplant. Cold cyst is another condition where you have jaundice in newborns or a little older age, where the bile tract is there. It is unlike in the atresia, here it is there, but it is deformed, and therefore it is actually distended. It stays there, resulting in hepatitis and jaundice. Diagnosis: ultrasound is one of the best diagnoses for these things. Medically, MRCP, MRI of the cholangiopancreaticogram is also very, very good. Early intervention, good results. Late results are bad. Remember, osteomyelitis in children is a condition which is commonly seen. Bloodborne infection, IV site infections from IV site can result in osteomyelitis of the growing bone. No symptoms except when that particular limb is elevated, the baby cries. So you lift that hand up and starts crying. So please keep osteomyelitis in mind. Again, the importance of this is early treatment is good. Delayed treatment, the entire bone is lost. It's sequestrum, and then you have a lot of problems with delayed osteomyelitis. Urinary tract infection in children is important, and I'll just summarize it by one line. 80% of the children who have confirmed urinary tract infection have a pathological cause for it. Unlike in adults, where you treat the urinary tract infection and find that it's the end of story, these people have a cause for it. And if you don't treat that cause, they will end up with long-term recurrent urinary infection, recurrent pyelonephritis, where the kidney is involved, and resulting in renal damage. So in children with confirmed, properly collected urine sample showing confirmed urinary tract infection, investigation is very important to rule out associated abnormalities. And some of the abnormalities that you can have is what is called posterior urethral valve in a male child. This is peculiar to male children because the posterior urethra is obstructed by a membrane, resulting in obstruction to the flow of the urine. And this is where I said history of dribbling is very, very important. If you have a male child whose mother gives a history of dribbling, actual dribbling, drop by drop or along the side of the scrotum and thigh, then please do make sure that you rule out posterior urethral valve, because there is obstruction at that level. This is a picture of the posterior urethral valve. You can see this part is the bladder. This is the urethra, which is obstructed, and that is why it is so distended. This is the level of the obstruction. That's the posterior urethral valve in a male. The obstruction can result in urine going backwards into the ureter from the bladder, and that's called vesico-ureteric reflux. And this is why it can affect the kidneys. This is a slide with the child with a much more severe reflux, where you can see the entire thing right up to the kidney being highlighted. Some important timings have to be noted by you, especially when you're dealing with a newborn baby. Newborns should normal term baby without sepsis or hypothyroidism should pass meconium in 24 hours. If they don't pass within 24 hours, we should start thinking of various conditions. And what I would like to highlight to you here is that if they don't pass in 24 hours, please don't stimulate them or give them a suppository or a suppository or an enema unless you have ruled out conditions. The easiest thing is, mother says baby has not passed, give him a suppository or a laxative. Child will pass, but you will be missing out various things. Most importantly, you will miss out anorectal malformations. You saw me show the photograph of the anorectal malformation. It is so obvious. Once you look at it, there is no orifice over there, there is no anus. Anybody can say a diagnosis of anorectal malformation. But you will be surprised by the number of times we have seen anorectal malformations coming here on the 3rd and 4th day because they have missed it out. All it needs is an inspection. Child did not pass your meconium, give him a laxative and forget about it, and you miss out on such important diagnosis. Urine, on the other hand, we can wait 48 hours, provided this child is well hydrated. This is because invariably during the passage of the baby through the vagina at delivery, baby will pass urine. And because it passed urine, we can wait 48 hours to make sure that there is no obstruction. Beyond 48 hours, start thinking of things like posterior valve, etc. In a male child, the testis is normally in the scrotum at birth. That is very, very crucial. It starts development at the level of the kidneys, and during the development process, it descends down, and at birth, it is in the scrotum. If it is not in the scrotum at birth, this needs to be followed up. And at 6 months to 9 months, a decision should be made. It has not descended or descended. If it has not descended, it has to be done because delay in treatment can result in atrophy of the testis. And jaundice, as I mentioned earlier, please don't let jaundice go beyond 3 weeks without looking at other causes of the jaundice. Otherwise, by 6 weeks, cirrhosis will start setting in. Babies with past meconium, we'll have to look at other conditions also, in addition to what I also mentioned, but things like prematurity, sepsis, and hypothyroidism. Coming to treatment in the newborn, in the babies, we divide them into 3 groups. Those that need immediate surgery, those that need intermediate surgery, and those that need elective once the child is grown a little older. The urgent ones are obviously things like anorectal malformations, diaphragmatic hernia, posterior valve, intestinal obstruction, malrotation, etc., which we cannot wait because once we wait, we will end up with a tragedy. The intermediate groups are the ones which we can wait for about 6 months to 9 months, like inguinal hernias, cleft lip, cleft palate, hydronephrosis, PU junction obstruction, etc. This is a picture of a baby with a hernia. You can see the swelling on the right side of the scrotum, inguinoscrotal swelling. They can wait for a couple of weeks if they are a newborn, but once they are about 6 months of age, we don't need to wait. The elective others include things like hydrocele, undescended testis. This is usually done at about 9 months to 12 months of age. Umbilical hernia, 2.5 years of age, etc. Older children, you have to keep things in mind like acute intussusception, where they have invagination of the small bowel into the large bowel, resulting in intestinal obstruction, colicky abdominal pain, vomiting, and distension. Intussusceptions are very commonly seen in children, and if picked up early before edema and etc. happen, simple procedure, non-surgical procedure of a pneumatic or a hydrostatic insufflation can take care of that condition. Abdominal pain in children is a common symptom. Almost all children will come and parents will come and complain that the child has abdominal pain. And if you ask a child, they'll always say there is pain. So how do you differentiate a significant pain from a not significant? If the pain lasts for more than 4 hours, it is possibly significant. If the child wakes up from sleep saying abdominal pain, it is possible. If there is associated symptoms like vomiting, diarrhea or abdominal distension, it is again significant. So these are some of the characters which help you to pick up important findings along with abdominal pain. Acute unilateral single-sided scrotal swelling in a male child is again a very, very important sign. It has to be seen by a surgeon. Torsion testis has to be ruled out, because if you wait more than 12 hours, you can end up with gangrene of the testis and you can lose the testis. So child will first of all take time to come to you for with this history, but please don't delay it beyond what is absolutely essential. Sudden choking of a child while feeding, especially with noisy breathing, please think of a foreign body in the trachea. That is such a common condition. Here you can see post foreign body aspiration, findings of obstructive emphysema, etc. And on endoscopy, this is what you see. Normal bronchus should be open like that, whereas that one shows a peanut in the bronchi. This is a foreign body in the esophagus, commonly seen. Children put coins in their mouth and they aspirate it into the trachea. Recently, we've been seeing a spot of mafta pin in 13 years and 15-year-old children. They keep it in their mouth, talking to their colleagues, suddenly laugh and it goes in. So that is again a thing which you have to be very careful when you have these children. When you have children, babies during picked up with antenatal problems, it is very important to counsel them, because if you don't counsel them, the parents are upset. They don't know what to expect. They have problems. So counseling, transfer to appropriate center where baby can be dealt with. While transferring, ensuring that the temperature is maintained and protected, we need to be given advices accordingly. Very importantly, also need to give advices about future pregnancies. Will the same condition occur in the further pregnancies? So these are all importance of antenatal conditions. Rare conditions are there. These are all nothing that you can go by, but you need to remember that this is an omphalocele where the entire intestine is outside the abdominal cavity. Because of that, there is a lot of temperature loss and respiratory distress. Another rare condition where you have a huge maxillary tumor in a newborn, not common. This is a sacral teratoma, which occurs in a newborn again. The importance of this is that immediately after birth, it is benign, but by two months of age, it becomes malignant. So you need to treat them urgently. This was one which we did recently. This is 300 grams this weight in a child who was about 2 kg. So you can imagine it's almost 1/3 the weight of the child. Meningomyelocele are again important because if it ruptures, it causes meningitis and problems with hydrocephalus. So it is very wide and varied. But what I would like to tell you is children withstand surgery very well. The old days where we were worried about will the child withstand anesthesia, will they withstand surgery is no more. With developments in surgical principles and in anesthesia, they will withstand surgery very well. But there are two things they will not withstand. That is a bad anesthetist and a bad surgeon. So unless you are delicately deal with these children, they can have very good healing and adaptation in children is fantastic. They are actually no problems of diabetes, hypertension, cholesterol, etc. So their healing is very good, and therefore their recovery is much better. Early treatment avoids unnecessary trauma to the child. Always treat the child as a part of the family, single unit. Don't isolate them from the family and then separate them out, and it can be very stressful. It's good to complete all essential operations, the elective ones, before the child goes to school, so that he is as normal as possible when he goes to school. When you are referring a patient to a pediatric surgeon, please remember, call and inform the surgeon so that they know what to expect and are ready for the thing. Discuss the case. Please do not mention the need for surgery. Leave that to the surgical team to decide, but they will decide when, how, why, where. Many often we find patients coming over here saying they were referred for surgery. Why are you wasting time taking history or chest X-ray? Why don't you take them straight to theater? So please do not do that. Pension time. The decision will be done by the team which is receiving it. Your weight carries weight in gold. So please make sure that you always talk. Remember these things: bilious vomiting in a newborn. Please don't let the sun set without ruling out malrotation because it's dangerous. Respiratory distress in the newborn. Learn to do a needle thoracentesis. No bag and mask if there is a CDH. When you're transferring a patient, make sure that you secure the airway. Very important. If this child is likely to have respiratory distress in transfer, intubate and send. And if you intubate, make sure it is well maintained. Secure the IV lines. Cover the baby very well, especially the scalp. The volume of the scalp is so much high in a child, they lose heavy amount of heat if you don't cover their head and rest of the body. Maintain hydration and good gastric decompression. With this, I would like to stop, and I hope I have given you enough. It's a nutshell, but just enough to make you what I would call a nurse pediatric surgeon. Thank you very much.
Now it's time for open discussion. Audience, if you have any doubts, you can clarify it. Now I invite Dr. Asma Bibi.
Can I interfere at this point? If there are no questions, it means only two things. One, you understood everything that I said and you have no doubts, which I don't believe is true. Second, which is more likely, is that it bounced all over your head and it didn't matter at all. I hope it is the first and not the second. Thank you very much.
Now I invite Dr. Asma Bibi to present the moment to Dr. Abraham as a token of our gratitude. Thank you, ma'am. Thank you, sir. Dr. Asma Bibi, a basic graduate of one college of nursing Kerala, with a second rank from Kerala University and a postgraduate of college of nursing CSC Valley. She had completed her doctoral studies in the year 2003 from University of Calicut. She did diploma in medical education, diploma in hospital management, diploma in public applications, training professional management, HIV/AIDS, TB, and she had 68 publications in index, peer-reviewed and non-index journals. Received many awards, including Best Citizen Award and Best Teacher Award. She is presently the member of Board of Studies in Nursing for 4 universities in India, academic She has wrote 8 books including concise textbook of pediatric nursing by Grade HCR and Pediatric Care Plan of JP Publishers. Contributed chapters for 5 books of nursing research and education. She is a life member of 6 professional associations and presently holding the office of the President of Nursing Research Society of India and core committee member of the Scientific Committee of Indian Nursing Council. It's my privilege to invite Dr. Asma Bibi to deliver the session on forensic nursing, implications in emergencies.
Ma'am. You keep it in water, tomorrow you can use it. Okay, good afternoon. All are alert?
Yes.
See, I will be talking to you about forensic nursing, importance in emergency nursing management. I don't know whether we need to learn forensic nursing or not. What is your opinion? Why do you want to learn forensic nursing? Where no, Any staff nurses who are working in ED here? Emergency department work in either staff nurses and Illa. I would come by anyway, just I wanted to tell you why we wanted to learn emergency nursing, I love forensic nursing for emergency nurses. You can just look at the PPT, you can see ED is the portal that funnels victims and perpetrators of violent crimes into the healthcare system. Dr. Menu Ravale പറഞ്ഞതുപോലെ casualty എന്ന് പറയുന്ന സ്ഥലം അഥവാ emergency department. The new name is emergency department or trauma care center എന്നൊക്കെ പറയും. This is the funnel. Victims comes to hospitals. Both victims and perpetrators also will come. Why we say like that? എന്തുകൊണ്ടാണ് അങ്ങനെ പറയുന്നത്? രാവിലെ keynote address Dr. Venu was telling you that emergency occurs at any time. Now we are all in this hall. Any emergency can happen. Yes, we will not be able to predict emergencies most of the time. So what happens is the victims and the perpetrators together may come also to emergency department, where most of the time the emergency department will be handled by the nurses. There may be physicians, emergency physicians are there. Still, emergency nurses are taking care of them most often. So, emergency nurses should know what is a forensic case, what is the difference between an MLC and forensic. Forensic, when we talk about what it constitutes and what is the role of the nurse in forensic nursing. Do we need to learn? Do every nurse need to know about forensic nursing? This is a very important question. And the questions are answered by Indian Nursing Council also now. And in India, we have, I'm not going with the slides, you will get the notes later. I wanted to talk to you about this. That is what I'm doing now. Indian Nursing Council also has identified that forensic nursing must be included in the syllabus. That is why in the new syllabus, which have been prepared this year and is implemented, the first and second semester students are undergoing that. They have made a modular course for nurses, all nurses. And also there is a specialized course for forensic nursing now in India. And what happens most of the time, it is written here, you can see ED is chaotic. When a trauma patient arrives, and staff members must do everything possible to save the patient's life. Our first principle in ED is we will be taking care of the golden hour to save the life of a patient, isn't it? Isn't it? Okay, we will be looking after the life of the patient first. But once you are taking care of life of the patient, sometimes something will be missing. So we must be careful that the evidence which is going to be helpful for the patient's rights should not be lost during your care. We will be taking care of the patient to save the life first, but we must be careful not to destroy or dismantle any evidence that may come to the court of law. You might have heard about so many things about Abhaya case. Sister Abhaya's documents were manipulated. Even when the internal organs were sent to the lab technician has altered the entry, isn't it? This chain of evidence has been lost because from the very beginning, when her body was taken out itself, bringing to the hospital, take after the post-mortem, all those things. So you know how the right of that lady has gone out. നമ്മളെല്ലാരും പത്രത്തിൽ വായിക്കുന്ന പലപ്പോഴും കാണുന്ന കാര്യങ്ങളാണ്. Recently we heard about the rule of the court verdict and how Soumya's case has been dismantled. We have seen Nadia Akramicha case. Chain of evidence, chain of custody has been mishandled, and the CD given to them has been taken away, isn't it? This happens. So what nurses can do for this is very important. So we must not be an agent for losing evidence. So nurses also must be trained to keep the forensic evidence properly. So an integral responsibility of the staff nurse is collection and preservation of forensic evidence for medico-legal cases. Emergency nurses must be trained for evidence recognition, handling of clothing, gross or trace evidence, documentation, packing of evidence, and use of chain of evidence form. There is a form called chain of evidence. When a patient enters itself, whatever you have seen, how you have reported, how you have registered, everything comes in a chain. That is called chain of evidence. Then what is forensic? It is pertaining to law. Forensic nursing is the application of nursing to the law. According to Joe Biden, you know Joe Biden, US president, the present US president. When he was vice president of US, he said this, forensic nurses' role as a connection between medicine and law, and believes that forensic nurses should be in every emergency room. This he stated nearly 20 years back when he was the vice president of US. Now he is the president of US, and almost all US hospitals have forensic nurses in the emergency department. Almost all hospitals, I want to tell you. But in Kerala or in India, we don't have forensic nurses in our emergency department. So what is forensic nursing? Application of forensic healthcare in the scientific investigation of trauma or death related to abuse, violence, criminal activity, liability, and accidents. Then Virginia Lynch, she is known as the mother of forensic nursing, has given the beautiful definition: application of forensic aspects of healthcare combined with bio-psycho-social education of the registered nurse in the scientific investigation and treatment of trauma, death, violence, or criminal activity and traumatic accidents sorry, within the clinical or community institutions. So this is now a widely accepted definition for forensic nursing, because the forensic nursing as a specialty has been developed by Virginia Lynch, and this was done in 1991. An association was also formed for forensic nurses, and they are the legal nurse. They are called as legal nurses of US by this Virginia Lynch. Who is a forensic patient? Forensic patient is any client or that person's significant with others whose nursing problems bring him or her to an actual or potential interaction with the legal system. Nursing diagnosis and nursing problem definition we all have learned. The actual or potential interaction with the legal system, that word is very important. When a client comes to you with this, they will be called as a forensic patient. And you can see that in emergency department, large number of patients comes with this, which may not be identified by many of the nurses at that time. When patient may be taken care, patient may be transferred to some other unit, then when taking history, there may be some evidences. But by that time, the evidences which have to be collected in the emergency department have been gone off. So the patient's rights will not be taken care. Then the objectives of this is as an introduction. I just told you this about, we talk about the importance of forensic nursing. Describe Indian Nursing Council role and their contribution towards forensic nursing speciality. List the major areas of forensic nursing. Types of forensic patients attending ED. List the types of evidence in ED. List the role of forensic nurse in emergency department. These are the points I am going to cover. Importance of forensic nursing. They learn law along with healthcare. So what they can do, the largest section of healthcare providers are nurses who take care of patients in the entire life cycle of individuals from birth to death. That means if a child is brought to ED also, the nurse has to take up the chain of evidence. If an adult is brought to the hospital ED, then also she has to take the evidence. If an old patient is coming, geriatric population, and then also she has to take the evidence. That means throughout the lifespan, nurses are seeing patients, especially in emergency department. Other specialty areas, you will get only the specific patients. For example, in a pediatric setup, you get only pediatric patients. If you are in a geriatric care ward, you will get only geriatric patients. And if you are in an adult ward, like adult specialties like cardiovascular or wherever it is, you will get only that type of patients. But in ED, you get all type of patients. That is why in this conference, we have included many types of specialties together in this class for the 2 days. So nurse is in a unique position to see all type of patients. That is what I want to tell you. Then throughout the entire curriculum, they learn a lot on assessment of individuals. See, from first year onwards, you are learning assessment of a patient, making care plans, taking history. And when you come to second year, you will be going for medical surgical patients. And the third year, you will be looking after the pediatric patients. Then in the fourth year, you will be taking care of the obstetrics and gynecology patients. That means for throughout your curriculum, you are seeing patients of different types, different age group. So you are in a unique position to help others, then provide whole lot of therapies and treatment for all ages with the explicit skill and right attitude. Then so the second point, they care the victims of violence. Wherever you are, especially in an ED, you have to care for victims of violence. The first point of contact in majority of emergency care institutions or situations are nurses. Then on-site care of patients at accidents. If you are in a mobile ICU, if you are working with a travel team, there also you are the person who will be going and meeting the accident patients. Then work in mobile, that I have already told you. I can see my students who have graduated from here had gone for EMS, and in most of the Gulf countries in ambulance, helicopters, all these places, these people are working and they go and pick up patients. Recently, one of the students who were here before was telling me how he is going with the helicopter and picking up patients from the desert during accidents or injuries or such things. So nurses are in a unique position for taking care of these type of patients. A nurse practice with the holistic framework of body, mind, and spirit. We are not taking care of one person. For example, if you are taking care of an orthopedic patient, an amputation is there. We are not thinking about above knee amputation or below knee amputation alone. We are taking care of a patient totally. We think about the patient in a holistic manner. So nurses are the most important people who can be trained or educated for taking care of forensic patients. That is the importance of forensic nursing. Then major areas of work for nurses, where nurses work: trauma care units, sexual assault response team, nurse coroners or forensic nurse, death investigators. ഈ കൊറോണേഴ്സ് എന്ന് പറഞ്ഞ പോസ്റ്റ്മോർട്ടം ഒക്കെ ചെയ്തിട്ട് അതിന്റെ റിപ്പോർട്ട് കൊടുക്കുന്ന ഡോക്ടേഴ്സ് ഉണ്ടല്ലോ, ആ ഒരു ഇതിൽ വരുന്നതാണ്. അത് നഴ്സസിന് they can be trained to give the report. That is what in US it is allowed now. And nurses attorney or legal nurse consultants, then psychiatric and mental health areas, correctional health, domestic violence, human rights protection institutions. All these places forensic nurses can work. Then who can become a forensic nurse? What INC says, Indian Nursing Council prescribed a detailed curriculum for forensic nurse practitioner. The basic qualification for forensic nurse in India is BSN, that is BSc Nursing, RNRM registration of any state of India having minimum 1 year experience after graduation, just like MSc Nursing. So once you get a forensic nursing diploma or a certificate after BSc, you will be taken as a specialist nurse in forensic areas, and you can go for it. And the same criteria applicable for a master's degree is applicable for forensic nursing also. According to INC, they can play an important role in bridging the gap between the law and medicine. And nurses trained in this field can document injuries, collect biological fluids, preserve clothing with evidence of assault, counsel victim, provide compassionate care to victims and family. Then INC says about 500 hours of theory and 1,440 hours of practical for this course. And the practical areas have been divided into 58 weeks. They will be going into different areas like this. You can see counseling centers, casualty, emergency and trauma centers, forensic department where autopsy, pathology, etc. are done. The pathological examinations of the tissues are done. Then forensic lab, police administration, witnessing different court proceedings, organ transplant centers, fertility centers, toxicology unit, correctional facilities. All these areas they have to go and learn. And totally this 38 weeks of posting is given to them. Then forensic nursing combines nursing practice and forensic in the scientific investigation of death and injury resulting from criminal activity and accidents. This is what INC defined forensic nursing. In addition to providing care, forensic nurses act as multidisciplinary team members with consultants to other nursing and medical professional and law enforcement. They receive advanced training in collecting and preserving evidence, treatment protocols, and legal proceedings and testimony. We will be coming to expert witness testimony later in this class. You should have a specialized training and all those things. Expertise for forensic nurse may be required in the following situations according to INC. They say arson, suicide and homicide, drug and alcohol abuse, bioterrorism, medical error, tissue and organ transplant, then sexual or physical abuse. Types of forensic patients. This has been identified by Pascalon. 24 types of patients are identified by this lady for forensic care. That is occupational injuries, transportation injuries, substance abuse, personal injury, child abuse. This has been 24 types of these patients have been come to her through a study. She has done a study in an emergency department and found that how many types of patients are coming for forensic care in an emergency department of 3 major hospitals in US. And she found that 24 types of patients are coming, and this is listed here. But in India, types of forensic cases in India, all cases of injuries and burns are coming under forensic. Then all vehicular, factory or other unnatural death, it comes only 10 items. Unnatural accident cases, especially when there is a likelihood of patient's death or grievous hurt. cases of suspected or evident sexual assault, cases of suspected or evident criminal abortion. That is why when there is criminal abortion, it becomes an MLC. What is MLC? Yeah, criminal abortion is an MLC. Then all cases of unconsciousness where its cause is not natural or not clear. All cases of suspected or evident poisoning or intoxication, cases referred from a court or otherwise for age estimation, cases brought dead with improper history creating suspicion of an offense, cases suspected of self-infliction of injuries or attempted suicide. Any other case not falling under the above categories but has a legal implication is also considered as a forensic case. So together 10 number is there in India. The other one in US, they have identified 24 types of forensic cases. Then we will see what are the role of forensic nurse in emergency department. The first one is registering a medico-legal case. Treatment, all legal formalities to be suspended till the patient is resuscitated. I told you, first thing is saving the life of the patient. Then, but see that you are not destroying the evidences. That is very important. Then identification, whether that said case falls under medico-legal case or not. I have just mentioned suspected injury, unconscious patient coming with a suspected injury, intoxication. Like that, if there is such things, you must identify it and mention it. Then intimation to police, acknowledgement of receipt. Once you intimate to the police, you should get a receipt. If you hand over something to the police, you should get a receipt and you should have a copy of it with you also, because sometimes they may miss somewhere, sometimes they manipulate, but when you are giving, it is not it should not be a manipulated thing. Once you give it, you should have a copy with you, whatever you have given, and you should get a receipt from them so that they will, there is a document saying that what you have given to the police. Then reporting of medico-legal case, report must be prepared in duplicate on proper performer, giving all necessary details. Avoid abbreviations, overwritings. Correction, if any, should be indicated with date and time. I was just telling that medical lab, pathology lab report has come altered, and the medical laboratory technician of that area has manipulated that it has not been received like that and all. So it should not happen. Report must be submitted to the authorities promptly. Medical legal documents should be stored under safe custody for 10 years. നിങ്ങൾ ഇവിടുന്ന് MLC കഴിഞ്ഞു പോയി ഡോക്ടർ ഒരു റിപ്പോർട്ട് കൊടുത്തു അത് കഴിഞ്ഞു എന്ന് വിചാരിക്കരുത് 10 വർഷത്തേക്ക് you should have all the documents in your medical library. Records library separate area should be designed or assigned for MLC cases or forensic cases, so that at any time if the court asks, you must be able to take it and give to the court. Then age, sex, father's name, complete address, date and time of reporting, time of incident, brought by whom. Brought by whom is not a big issue, because you know people were reluctant to give their addresses when they were bringing the patient. When I was working as a staff nurse, I had a very bad experience. One patient was brought from Calicut city to Calicut Medical College casualty, and the patient was transferred to surgical unit where I was working. And what happened is, patient, there was no name written. Ikoran was written as a name, and patient died. The person who brought the patient was not identified by the receiving nurse, and we had a lot of trouble in the court. and media came. Who is this patient? This is an unnatural death. It was an accident death, but he had a head injury. So he was brought to the surgical unit after surgery, and people who were taking care of the patient was asked for witnesses and testimony. All those things happened long back. So in 1980s, this has happened. So what will happen now? You can just imagine. So all MLC must be informed to the police for taking legal evidence. If the patient is dying, inform the magistrate to record dying declaration. See, we are talking about so much of emergency, how the death will come, all those things. And you must be able to perceive whether the patient is going to die or not. If the GCS is low, 3, 4 like that, we know that the patient may not survive. We know that the score of Scopus score is going down, or for an obstetric patient, he may have a fall. Antenatal patient had a fall and a bleeding. It may be a fall or it may be an abuse. Who knows? That also I have experienced when I was working in labor room. Patients were brought, ladies were brought with bleeding, antenatal bleeding. We think that antepartum hemorrhage, we take care of all those things. Antepartum hemorrhage was created by whom? By the bombardment of the husband. The lady was brought like. So we have to be very careful with identifying things and informing the police about this. Then evidence collection is the third important thing. The first one is history collection. When you are taking history, you should take an objective history. If you felt that there is a confusion in telling you the details, what you have to do, you have to write the behavior of the patient and the bystander, whoever is accompanying the patient, with objective medical terms, because most of them will tell you lies. See, when I was working in pediatric ICU, pediatric IMCH, Calicut Medical College, IMCH work in the summit, I have seen a child with a vaginal injury, and the mother was telling that the child has fallen down and had a stick went into. It was not that. Mother was telling different stories, and we found that it was a sexual assault. You understood what I'm telling you? Because now, when you're taking history, you must be very careful. You have to observe their behavior, observe their facial expression, and document it clearly. And you should not write your inference. What you feel should not be written. What you have seen should be written. What the patient has told you, you have to write. But I feel that patient is lying. You cannot write. We don't know whether the patient is lying or not. Okay, so we should say the facial expression of the patient is like this. With objective terms, you should write. History should be taken properly, write it clearly, mention all the details properly. Then second is photography. And നിങ്ങൾക്ക് ഫോട്ടോഗ്രാഫ് എടുക്കാന്നൊക്കെ ഒരു തോന്നലുണ്ട്. എല്ലാവരുടെയും കയ്യിൽ മൊബൈൽ ഉണ്ട്. മൊബൈൽ കൊണ്ടല്ല എടുക്കുക. അതിന് ഫോറൻസിക്കിന് particular camera ഉണ്ട്. Good camera has to be used. Photographs are taken, attach a consent form. Photo എടുക്കുമ്പോൾ അവരുടെ consent എടുക്കണം. Polaroid or digital camera should be used for taking images. One photograph should fill all full body shot. That includes the victim's face. ബാക്കിയുള്ളത് ഏതൊക്കെയാണോ ഏരിയാസ് നോക്കി ഫോട്ടോ എടുക്കുക. ഫോട്ടോ എടുക്കുമ്പോൾ എപ്പോഴും 4 print എടുക്കണം. 2 sides 4 print ആയിട്ട് എടുക്കണം. 4 images should be there for each this thing. If you take one side, take 2, this side 2, like that. 2 and with a ruler in between, so that they will be able to identify which side, which location, everything like that. And forensic nurses are authorized to take photographs. That is what I want to tell you. Usually, nurses who are not prepared for forensic nursing will not be allowed to take photographs. The police will come with some photographer and will take the photos. It is like that. But if forensic nurses are there, they are authorized to take the photographs. They are supposed to keep the photographs properly. The cause of injury must be written on the back of the photograph, and patient's name must be clearly written on the back of the photograph. Patient's identification mark should be marked. All these has to be kept. Then describing and diagramming. This is another important aspect of forensic nursing. A written description of assessment findings, including, this is not coming under history. This is describing, you are describing what you have seen with the patient. And you may say that there is an injury with 3 centimeters like this. It is a sharp object injury. Like that and all, you write, then whether it is a lacerated injury, whether it is only a sharp injury going deep into it, how much the depth of the injury, like that and all. That is called describing and diagramming in reporting these cases. For that, you have to use body charts. This charts is available. Most of the hospital ED it is available. You can just look and mark on these things. Then another chart also is there. This is the sex characteristics of the patient. This also is very important, and this is very useful for describing and diagramming the patient's injuries. Then documentation and chain of evidence. Remember that the documentation is an important part of chain of evidence and should include, when you are writing these evidences, site and time of assault, nature of physical contact, race and number of assailants. Race and number of assailants usually we will not do in India because we are not racial people. We don't have our apartheid. But in US and all, they have different races of people, like whites are there, Native Americans are there, then Black Americans are there. Now we will not call them Negroes. We call them as American and Black Americans. Like that and all. Indian Americans. Indian Americans, no, Native Americans comes in that. Now they call us South Asia, like that and all they call. Then relationship to assailants. This is very important. Sometimes you may not think that this has been created by the people inside the house itself. It may be a father, it may be a mother. If a child is brought with a battered baby, BBS, battered baby syndrome, it may be the relatives. I can tell you 98.9% battered baby syndromes are done by father and mother or elders in the family. So we have to be very careful when we are stating the relationship, who brought the patient, who has committed this crime. That is important. Then actual and attempted penetration of which orifices by penis, that is coming in sexual assault. So many things you have to look for sexual assault, what all have been done. I haven't mentioned everything like that, whether the patient, the person rapist has used condom, then whether the lady or whether the girl or the victim had sexually transmitted diseases. Within 24 hours, we may not be able to get it, because today morning, Dr. Aruna was talking to you about sexually active girls. This girl may had sexual activity with somebody else also. We may not be knowing, but for the period, you take blood and semen, whatever is available, saliva, injuries, bite marks, all these you have to look into, nail abrasions, all these things. And you have to document what all things you have seen in the proper way. There is sequence of evidences should be written in the proper manner. That is what it means. Then whether I have told you this, use of tampon, use of change of clothes, contraceptive use, current pregnancies, allergies, victims' general appearance and response during examination, physical injuries, all these has to be reported. Then collecting physical evidence. This നമ്മുടെ നാട്ടിൽ ഒരു ചോദ്യമുണ്ട്, ഏത് കുറ്റവാളിയും പോയി കഴിഞ്ഞാൽ, കുറ്റം കഴിഞ്ഞു പോയാൽ എന്തെങ്കിലും ഒരു ക്ലൂ ഇട്ടിട്ടേ പോവുള്ളൂ എന്നല്ലേ പറയലില്ലേ? ഒരു ക്ലൂ അവിടെ കാണും എന്ന് പറയും. അത് ഒരു സത്യം തന്നെയാണ്. അതാണ് എഡ്മണ്ട് ലൊക്കാർഡ് എന്ന് പറയുന്ന ഡോക്ടർ, he has proposed a theory called Locard's principle of exchange. This principle is universally followed in collecting physical evidence. The theory states that the criminals have marks of their passage, while on the other hand, at the same time, by inverse action taken with them on their body or clothing, evidence of his deed. നമ്മൾ പോകുന്നിടത്ത് മാത്രമല്ല, പോകുന്നവരും കൊണ്ടുപോകും എന്തെങ്കിലും ഒരു എവിഡൻസ്. ദാറ്റ് ഈസ് വൈ ഈ പെർപെട്രേറ്റേഴ്സിനെ നമ്മൾ പരിശോധിക്കുകയാണെങ്കിൽ ചിലപ്പം യു വിൽ സീ ദ ഹെയർസ് ഓഫ് ദി പേഷ്യന്റ്, നെയിൽസിലൊക്കെ അത് കാണും, ഇത് പിടിച്ചു വലിച്ചതിന്റെ എന്തെങ്കിലും ഒന്ന് കാണും, അല്ലെങ്കിൽ യു ക്യാൻ സീ ദാറ്റ് ദ ക്ലോത്ത്സ് വെർ ടോൺ, സംതിങ് വിൽ ബി ടേക്കൺ വിത്ത്. സോ രണ്ടുപേരെയും ഒരേപോലെ ട്രീറ്റ് ചെയ്യണം എന്നുള്ളതാണ് ഫോറൻസിക് മെഡിസിൻ പറയുന്നത്. Whenever there is contact between two objects, mutual exchange of material occurs. Physical evidence is defined as any object or part of an object showing that a crime has occurred or establishing a relation between victim and perpetrator. Physical evidence can be tangible or transient, such as redness or trace of body fluids. Then physical evidence il namakku cloth ningal kandittundavom, police ഒരു ക്രൈം സീൻ കഴിഞ്ഞാൽ ഒരു ഇതൊക്കെ കെട്ടിയിട്ട് അതിനകത്തുനിന്ന് ചെരുപ്പ് കഷ്ണങ്ങൾ എന്തൊക്കെ ഉണ്ടോ അതൊക്കെ എടുക്കുന്നു, ഇതൊക്കെ പെറുക്കി ഒരു പ്ലാസ്റ്റിക് ഇതിനകത്ത് ആദ്യം വേറൊരു ഇത് വെച്ചിട്ട് അതിനകത്ത് ഇടുന്നു ഒക്കെ സിനിമയിൽ കണ്ടിട്ടുണ്ട് അല്ലേ? ജീവിതത്തിൽ കണ്ടിട്ടുണ്ടോ എന്ന് അറിയില്ല, സിനിമയിൽ കണ്ടിട്ടുണ്ട്. ദ സെയിം തിങ് ഹാപ്പൻസ്. അവിടെയാണ് നമ്മൾ അറിയേണ്ടത് ഇത് വളരെ ഇമ്പോർട്ടന്റ് ആയിട്ടുള്ള ഒരു കാര്യമാണെന്നുള്ളത്. ഗ്ലൗസ് നമ്മൾ ഇടണം, നമ്മുടെ കൈ കൊണ്ട് എടുക്കരുത്. പിന്നെ ഗ്ലൗസ് ഷുഡ് ബി ചേഞ്ച്ഡ് ഓഫൻ ഡ്യൂറിങ് എവിഡൻസ് കളക്ഷൻ. ലേബൽ ഓൾ പാക്കേജസ് യൂസ്ഡ് ഫോർ എവിഡൻസ് കളക്ഷൻ വിത്ത് ടൈം, എല്ലാം ഡേറ്റും ടൈമും പേഷ്യൻസ് നെയിമും ഡിസ്ക്രിപ്ഷൻ പക്ക ആയിരിക്കണം. ഒരു കാരണവശാലും ഡോക്യുമെന്റേഷനിൽ ഒരു തെറ്റും വരാൻ പാടില്ല. ഓൾസോ ഇൻക്ലൂഡ് നെയിം ഓഫ് ഹെൽത്ത് കെയർ പ്രൊവൈഡർ, നിങ്ങളുടെ പേര്, കളക്ട് ചെയ്ത ആളുടെ എഴുതിയ ആളുടെ പേര് വേണം. Names with initials of everyone who handled the material. ഒരാളല്ല, ആരൊക്കെ ഉണ്ടോ അവരുടെ ഒക്കെ പേര് വേണം. ഇതൊക്കെ എഴുതാം. ഈ ക്ലോത്തിങ് ഒക്കെ എടുക്കുമ്പോൾ നിങ്ങൾ കുടഞ്ഞ് മടക്കി വെക്കാമെന്ന് വിചാരിക്കരുത്. എടുത്തു കഴിഞ്ഞാൽ ഒരു കാരണവശാലും കുടയാൻ പാടില്ല. എന്താന്ന് വെച്ചാൽ അതിനകത്ത് ചിലപ്പോൾ ഹെയർ കാണും, നെയില് കാണും, ടീത്ത് കാണും, ഈ പേഷ്യന്റ് ബിലോങ്ങിങ്സ് കാണും. ഇതൊക്കെ എവിഡൻസ് ആണ്. സോ യു ആർ നോട്ട് സപ്പോസ് ടു ഡു ദാറ്റ്. You should not use your hands. You hold it properly with whatever evidence you have and pack it in the designed packages will be there. എല്ലാം പ്ലാസ്റ്റിക് കവറിൽ ഇടാൻ പറ്റില്ല, കാരണം പ്ലാസ്റ്റിക് കവർ നമ്മൾ ഇത് ഫിക്സ് ചെയ്യുമ്പോൾ മോയ്സ്ചർ മേ കം, ഇറ്റ് മേ ഡിസ്ട്രോയ് എവിഡൻസ്. സോ ഓരോ ഐറ്റവും പാക്ക് ചെയ്യാൻ ഓരോ സ്പെഷ്യൽ പാക്കേജിങ് ഉണ്ട്. ദാറ്റ് ഹാസ് ടു ബി ഡൺ. ഇത് മുഴുവൻ പറയാനുള്ളതോ അല്ല ക്ലാസ് എടുക്കാനുള്ളതല്ല, ഞാൻ ജസ്റ്റ് നിങ്ങൾക്ക് തരികയാണ്. ഒരു ഫോറൻസിക് നഴ്സിന് എന്തൊക്കെ ചെയ്യാൻ പറ്റും എന്നുള്ളതിന്റെ ഒരു അവബോധം തരിക എന്നുള്ളതേ ഉള്ളൂ. ഈ ക്ലാസ്സിൽ ഒരു വലിയ ഒരു വർഷത്തെ കോഴ്സാണ് ഫോറൻസിക് നഴ്സിംഗ് ഇൻ എമർജൻസി. അതിന് എന്തൊക്കെ വരും എന്നുള്ളത് അതിന്റെ ഒരു ചെറിയ ഒരു നട്ട്ഷെൽ only I can give you. So clothing is a physical evidence. That is what I want to. If there is chappals, all those comes under physical evidence. Then forceps with plastic coated tips are used to carefully remove hair, fibers or other debris from the body. Patient മരിക്കുകയാണെങ്കിൽ അവിടെ എടുക്കാനുള്ള ഇതൊന്ന് അല്ല, പേഷ്യന്റ് ജീവിച്ചിരിക്കുകയാണെങ്കിൽ പോലും ഇതൊക്കെ ഉണ്ടെങ്കിൽ നിങ്ങളത് പാക്ക് ചെയ്യുന്നത് എങ്ങനെ വേണമെന്ന് കണ്ടെയ്നേഴ്സിന്റെ കാര്യമൊക്കെ പറഞ്ഞിട്ടുണ്ട്. നിങ്ങൾക്ക് ഇതിന്റെ നോട്ട് അയച്ചു തരും കേട്ടോ. Don't worry about it. You can read it. Then, so evidence has to be collected like this. I don't know whether you might have seen a film, a Hollywood film, Man on Fire. Anybody? Man on Fire? No. Man on Fire is Main actor is Denzel Washington. He's an Oscar Award actor. Equalizer the cinema. Part 1 and 2 is there. This is also Hollywood, a very famous film. In Man on Fire, what he says, bullets always tells the truth. The hero says like that. Here also, if there is a bullet that says the truth. You understood what I mentioned? If a patient's body contains bullet, the younger bullet in the younger tokinala bullets always tells the truth. That is very important. അതുകൊണ്ട് bullets കിട്ടുകയാണെങ്കിൽ ആ ട്രൂത്ത് നഷ്ടപ്പെടാതെ സൂക്ഷിക്കേണ്ടത് എമർജൻസിയിലുള്ളവരോ അല്ലെ ട്രീറ്റ് ചെയ്യുന്നവരുടെയോ കടമയാണ്. It should be wrapped in coats to preserve evidence and then placed inside another container such as a cup, envelope or bag. Do not use metal instrument to touch the bullet. എന്തുകൊണ്ടാ? അതുകൊണ്ട് പ്ലാസ്റ്റിക് ടിപ്ഡ് ആയിട്ടുള്ള ഫോഴ്സപ്സ് കൊണ്ട് വേണം ഇതെടുത്ത് വെക്കാൻ എന്ന് പറയും. ഈ ബുള്ളറ്റ്സിന്റെ പുറത്ത് ചിലപ്പോൾ മെറ്റൽ ഇതുണ്ടാവും. നിങ്ങൾ ഇത് ഉപയോഗിച്ച് കഴിയുമ്പോൾ അതിന്റെ ചില വളയുകയോ പിടിക്കുകയോ നിങ്ങളൊരു ആർട്ടറി ഫോഴ്സപ്സോ ആലിസിന്റെ ക്ലിപ്പോ ഒക്കെ എടുത്തിട്ട് ഉപയോഗിച്ചാൽ ദർ വിൽ ബി ഓൾട്രേഷൻ ഇൻ ദി ബുള്ളറ്റ്. അത് പിന്നീട് ആ തോക്കിന്ന് വന്നല്ല എന്ന് പറഞ്ഞ് വാദിക്കാൻ കാശ് കൊടുത്ത ആളൂരിനെ പോലുള്ള വക്കീലന്മാരുണ്ടാവും. They will come and do that nonsense. അല്ലേ? And പാവം victim will never get the justice. That is it. So remove bullets or fragments with plastic shielded forceps and handle it as little as possible. Body fluids, high intensity lamp can be used to visualize the body fluid. Body fluid dry. Dry body fluid in the marks. That is why wet swabs marks in the body fluid. For example, after a sexual assault, there may be semen, there may be vaginal secretions. All these has been dried sometimes. So, but we have to collect it. And we know that when we wanted to do a DNA testing, we use blood, saliva, semen, all these things will be used. So you have to be very careful while collecting these things. Then toxicology screening also, laboratory specimens for toxicology screens and DNA reference samples should be collected from the victim. The blood, saliva and semen are usually used for DNA testing, that I have told you now. As many as 40% of rapists are thought to use condoms during commission of the crime. Why? There is a saying that most of the rapists are sexually dysfunctional. You know that? They are psychic little bit. They are not normal people in a way, because they are not sexually functional in the proper way. They wanted to experiment with people. There's a psychology behind it. That is what psychologists talk about rapists. They do cruelty because they are dysfunctional. This also must be remembered. So seminal fluid may not be available sometimes. Not all will have seminal fluid because they are dysfunctional. So ellarum vijarikenda rape kayna seminal fluid kittuennonnum vijarikenda. Not all, but studies says that 34% of people rape you may not get seminal fluid ennu parayum. അതുകൊണ്ട് അതൊക്കെ നിങ്ങൾ നോക്കി വേണം ചെയ്യാൻ. നിങ്ങൾ എടുക്കുമ്പോൾ DNA ടെസ്റ്റിന് കൊണ്ടുപോകാനായിട്ട് അത് കിട്ടുമെന്നൊന്നും വിചാരിച്ചിട്ട് ചെയ്യേണ്ട. കിട്ടുന്നതൊക്കെ എന്താണോ, whatever is available, you collect and make chain of evidence so that the victim will get justice. The nurses have no responsibility, ille? Don't you feel so? Okay. The following step may be taken to preserve evidence. Chain of evidence undakiya pora. You have to preserve the evidence also. Do not move anything unless absolutely necessary. To the extent possible, avoid contaminating evidence. photograph or video. Then protect forensic evidence from other elements. Record and identify. This is all I have told you. And avoid cross-contamination of things. Isolate witness from each other and from other person and record their statement on the statement or observation report in the prescribed format. This is very, very, very important. Why? Ippa parnayirikilla pinne paraya. Pinne endengilum oralu parnja statement kettittu matte aalu adu repeat cheyan sadhyadundu. Pinne ivaru thammil ellarum kude oru sakhya undakkan sadhyadundu, oru team aagan sadhyadundu. So collect evidences, take the report, record it separately, and don't allow these people to come together and discuss with it. നമുക്ക് ഇങ്ങനെ പറയാമെന്ന് അവസാനം തീരുമാനത്തിൽ എത്തുവരും അല്ലേ? അമ്മയെ തല്ലിയാലും രണ്ട് പക്ഷം ഉണ്ടെന്നാ. പിന്നെ ഈ പക്ഷക്കാർ ഒന്നാകാനും സാധ്യതയുണ്ട്. നിങ്ങൾ കേട്ടിട്ടുണ്ടല്ലോ സാക്ഷികൾ കൂറുമാറിയെന്ന് അല്ലേ? പിന്നെ 164 സ്റ്റേറ്റ്മെന്റ് കൊടുക്കാൻ മജിസ്ട്രേറ്റിന്റെ അടുത്ത് പോകണം. All this happens. So if you are careful, this will not happen. So this is very important. Do not disturb a computer when it is a part of an incident scene, and immediately notify both the chief and IT section of the hospital. അറിയിക്കണം ഇങ്ങനെ ഈ ഇത് ഉണ്ടെന്ന് ഹോസ്പിറ്റലിൽ ആണെങ്കിൽ അല്ലെങ്കിൽ IT ഉള്ള ആരാണോ ആ ഏരിയയിലുള്ളത് അവരെ അറിയിച്ചിരിക്കണം ഇതൊരു സീനിലുള്ളതാണ്. എന്താണെന്നറിയോ? കമ്പ്യൂട്ടറിലെ എവിഡൻസസ് റേസ് ചെയ്യാൻ എളുപ്പമാണ്. People can even operate remotely if they know the password of the computer. And they open together. I know in our institute, when there is a need for a repair and all, the people who are looking after the computer sitting in a remote area will ask, you open this area, that area, and they will tell you what to do with the computer. So it's so possible. So they may erase all the details in the computer. നിങ്ങൾ കേട്ടിട്ടില്ലേ കമ്പ്യൂട്ടർ ഹാർഡ് ഡിസ്കിൽ ഒന്നും ഇല്ല അല്ലേ? വാട്സപ്പ് ചാറ്റ് എല്ലാം പോയി എന്നൊക്കെ നിങ്ങൾ കേൾക്കുന്നുണ്ടല്ലോ. ഇപ്പം റീസെന്റ് yesterday ആരെ അറസ്റ്റ് ചെയ്തേ? ശിവശങ്കറിനെ അറസ്റ്റ് ചെയ്ത്. It's only because of the WhatsApp messages were available and ED could take him in, isn't it? So this is very important. The same way mobile phones also. Mobile phone undengile, cell phone undengile endu cheyanam nu vecha, take precaution to safeguard the information on the device by turning off the device as quickly as possible, removing the SIM card and conducting the institutional operations. അതും വളരെ ഇമ്പോർട്ടന്റ് ആണ്. നിങ്ങൾക്ക് ഒരെണ്ണം അങ്ങനെ കിട്ടുകയാണെങ്കിൽ. ഇതൊന്നും ഇവിടെ ഇപ്പൊ പാലിക്കപ്പെടുന്നില്ല കുട്ടികളെ. എന്താന്ന് ചോദിച്ചാല് ഫോറൻസിക് നഴ്സസ് ഇല്ല ഇവിടെ. So once forensic nurses comes in, we may be able to do all this by the nurses itself. Then chain of custody, forensic nurses rule. ഈ chain of custody എന്ന് പറഞ്ഞാൽ എന്താ? കസ്റ്റഡി വെക്കാന്ന് പറഞ്ഞാൽ എന്താ? നമ്മുടെ അണ്ടർ കൺട്രോളിൽ വെക്കുക. ഈ ചെയിൻ ഓഫ് കസ്റ്റഡി എന്താ? ഫോറൻസിക് പേഷ്യന്റിനൊക്കെ നമ്മൾ അണ്ടർ കൺട്രോളിൽ വെക്കുന്നതാണോ? അല്ല. Chain of custody refers to the paper trail that ensures integrity of evidence by documenting who has handled the evidence in every step of collection and processing. And chain of custody will be closely scrutinized in the court, and if it is broken or compromised, may be subjected to challenge and allegations of tampering and mishandling of the evidence. So adu sambhavikkadirikkan nammal nokkanam. Chain of custody begins as soon as the nurse locates and collects the evidence. ആ സമയം തൊട്ട് പേഷ്യന്റിനെ നമ്മൾ റിപ്പോർട്ട് കൊടുക്കുന്നത് വരെയും, and this chain of custody of all the documents till you hand over these documents to the legal people. അതുവരെ നിങ്ങൾ ഇത് കൃത്യമായിട്ട് സൂക്ഷിക്കണം. എന്ത് കൃത്യമായിട്ട് സൂക്ഷിക്കണം എന്ന് പറയാൻ കാരണമുണ്ട്. എന്താണെന്നറിയോ? Do you know why? ഹോസ്പിറ്റലും സേഫ് ആണെന്ന് പറയാൻ പറ്റുമോ? നിങ്ങളെല്ലാം വേണമെങ്കിൽ കബേർഡിലെടുത്ത് പൂട്ടി വെച്ച് പോയി എന്ന് പറയാം. നിങ്ങൾക്കൊരു കോൺട്രബാൻഡ്, നമുക്ക് നാർക്കോട്ടിക് ഡ്രഗ്സ് വെക്കുന്നതിനൊക്കെ കോൺട്രബാൻഡ് ഇതൊക്കെ ഉണ്ട് അല്ലെ? അതുപോലൊക്കെയുള്ള ഏരിയ ഒക്കെ ഉണ്ടാവും. ബട്ട് നിങ്ങൾ സിനിമ കാണുന്ന പോലെ somebody may end, somebody may take off. അത് വരാതിരിക്കാനാണ് ചെയിൻ ഓഫ് കസ്റ്റഡിക്ക് ഇമ്പോർട്ടൻസ് കൊടുക്കുന്നത്. പിന്നെ അപ്പിയറിംഗ് ഇൻ കോർട്ട്, എക്സ്പെർട്ട് വിറ്റ്നസ്. നിങ്ങൾ എപ്പോഴും നിങ്ങളെ വിളിക്കുക എക്സ്പെർട്ട് വിറ്റ്നസ് ആയിട്ട് വിളിക്കും. കാരണം യു ആർ ദ പീപ്പിൾ ഹു ഹാൻഡിൽ ദ എവിഡൻസ്. യു ആർ ദ പീപ്പിൾ മെഡിക്കലി ഫിറ്റ് ഫോർ ഗിവിംഗ് എവിഡൻസ് ഫോർ ദി എക്സ്പെർട്ട് വിറ്റ്നസ്. ഈ എക്സ്പെർട്ട് വിറ്റ്നസ് എന്ന് പറയുമ്പോൾ പേഷ്യന്റ് എല്ലാ കാര്യവും പറയാനൊന്നുമല്ല നിങ്ങളെ വിളിക്കുക. നിങ്ങൾ എന്ത് എവിഡൻസ് വന്നപ്പോ എങ്ങനെയായിരുന്നു പേഷ്യന്റ്, എന്ത് എവിഡൻസ് നിങ്ങൾ കണ്ടു, അത് എവിടെ വെച്ചു, എങ്ങനെയായിരുന്നു എന്നൊക്കെ ഉള്ളത് കൃത്യമായിട്ട് നിങ്ങൾ അതിന് ട്രയല് ശരിക്കും നിങ്ങൾ പഠിച്ചിട്ട് വേണം കോർട്ടിൽ പോകുന്ന സമയത്ത്. നഴ്സസിനെയൊക്കെ കോർട്ടിൽ വിളിക്കും. ഐ ഹാവ് ബീൻ ടു കോർട്ട് ഫോർ വിറ്റ്നസിങ് സർട്ടൻ തിങ്സ്, സോ ഐ നോ ഹൗ ദേ വിൽ ബി ആസ്കിങ് ക്വസ്റ്റ്യൻസ് ആൻഡ് ഓൾ. ഐ ഹാഡ് എ വെരി I will say it's a good experience also. When I was teaching in Medical College Calicut, nursing college പഠിപ്പിക്കുന്ന കാലത്ത് ഒബ്സ്ട്രിക്സ് പഠിപ്പിച്ച ടീച്ചർ എന്നുള്ള നിലയ്ക്ക് I was called to the court. മഞ്ചേരി കോർട്ടിൽ എന്നെ വിളിച്ച് എനിക്ക് ഇപ്പോഴും ഓർമ്മയുണ്ട്. ഒരു മഞ്ചേരി ഡിസ്ട്രിക്ട് ഹോസ്പിറ്റലിൽ ഒരു പേഷ്യന്റ് ഡെലിവറിന്റെ ടൈമിൽ കുട്ടി മരിച്ചു. അത് നഴ്സസ് ഡെലിവറി എടുത്തത് കൊണ്ടാണ്, ഡോക്ടർ വരാഞ്ഞത് കൊണ്ടാണ് എന്നുള്ള ഇത് വെച്ചിട്ട് അവർ കേസ് കൊടുത്തു. കേസ് കൊടുത്തപ്പോൾ കുട്ടി മരിച്ചത് നഴ്സസിന്റെ കുഴപ്പമാണെന്ന് ആക്കി തീർക്കാനും ഡോക്ടറിന്റെ പേരിൽ നിന്ന് ഇത് വാങ്ങാനുമായിരുന്നു അവർക്ക്. അപ്പം നഴ്സസ് എലിജിബിൾ അല്ല ഡെലിവറി എടുക്കാൻ എന്നുള്ളതായിരുന്നു ഒരു കണ്ടംഷൻ. I was schooled. I did a comparative study of the medical syllabus of obstetrics and nursing syllabus, and every doctor and the nurse, according to the council rule, have to take 20 normal cases, and every nurse is prepared after that. Every doctor is also prepared. MBBS doctors prepared with that. So I went with the syllabus comparison, and I have given the witness like that, and the nurse was relieved from court from paying a compensation to the family. അതുകൊണ്ട് ഡോക്ടറും സേഫായി. നഴ്സ് എടുത്തതുകൊണ്ട് തെറ്റിയതല്ല എന്നുള്ളത് വന്നു. അങ്ങനെയൊക്കെ സംഭവിക്കാം. അപ്പൊ നമ്മൾ പഠിച്ചിട്ട് പോകണം. നമ്മൾ എന്താണ് പറയാൻ പോകേണ്ടത്, നമ്മൾ എന്താണോ ചെയ്തത് അത് സത്യസന്ധമായിട്ട് പറയാനുള്ള ആർജവും നഴ്സസിനുണ്ടാവണം. You should show that you are assertive, you are capable in your profession, you are knowledgeable in your profession. Whatever you do it properly. Adairikkanam your thoughts. Then role in crisis intervention. When a patient is coming to you in the ED with a forensic incident or an MLC, I told you emergency is not, we cannot predict it. We may predict flood predict ചെയ്യും അല്ലേ, മെറ്റീരിയോളജിക്കൽ സർവേ വെച്ച് ഫ്ലഡ് പ്രഡിക്റ്റ് ചെയ്യും. അത് പറഞ്ഞ് കേൾക്കാതെ കടലിൽ പോയാൽ ചിലപ്പോൾ they may go into the sea. അങ്ങനെ സംഭവിക്കാം. പിന്നെ എർത്ത് ക്വേക്ക് പ്രഡിക്റ്റ് ചെയ്യും. പക്ഷെ most of the road traffic accidents, anybody can predict? No. If I'm standing here, I may fall down, I may have a pre-stroke something, I may fall down, isn't it? Is anybody can predict that? No. Such things happens. അങ്ങനെ പ്രഡിക്റ്റബിൾ അല്ലാതെയാണ് ഇത് വരുന്നത്. അതിപ്പം എല്ലാവർക്കും അത് ടോളറേറ്റ് ചെയ്തോളാമെന്ന് പറയാൻ പറ്റില്ല. എന്റെ വീട്ടിൽ ഒരാൾ മരിക്കുന്നു, പെട്ടെന്ന് ഒരാൾ മരിക്കുന്നു, ഹാർട്ട് അറ്റാക്ക് ആയിട്ട് മരിക്കുന്നു, ഒരു പേരന്റ് മരിക്കുന്നു, ഒരു മകൻ മരിക്കുന്നു, ഒരു മകളും മരിക്കുന്നു. These are all crisis situations where nurses are the people who can give these people psychological support. So crisis intervention is also a role for forensic nurses. And more importantly, because they are working in emergency situations. And also in critical care unit, they may be working in ICUs, they may be working in areas of fertility centers, they may be working in organ transplants, all these places they are working. Yeah, there crisis intervention is a very important topic which they have to take. So in putting in nutshell, they work for identification of the forensic patient, care of the survivor, care of the perpetrator. ഈ പേഷ്യന്റ് എന്ന് പറയുന്നത് നമ്മൾ ഓത്തെടുക്കുമ്പോൾ പറയുന്നുണ്ട്, ഫ്ലോറൻസ് നൈറ്റിംഗലിന്റെ ഓത്തെടുക്കുമ്പോൾ ഐ വിൽ കെയർ മൈ പേഷ്യൻസ് വിത്തൗട്ട് കൺസിഡറിങ് കാസ്റ്റ്, കെയർ, ക്രീഡ്, കളർ അല്ലേ. അവിടെ നമുക്ക് വിക്ടിമും പെർപെട്രേറ്ററും ഇറ്റ്സ് ഓൾ പേഷ്യൻസ് ഫോർ us. അതുകൊണ്ട് നമുക്ക് രണ്ടുപേരെയും മാറ്റി നിർത്താൻ കഴിയില്ല. So we will be taking care of both. But when it comes to rightness and justice, we always should stay in the path of right. That's all I wanted to tell you. Then injury pattern, documentation, injury measurements, responsibilities to put again once more, treating and educating patients, examining prospective suspects as part of investigation, providing crisis intervention. All these comes and providing testimonies in court as expert witness, and concluding, forensic nursing is relatively a new field of nursing. Its job growth forecast shows promising demand for forensic nurses. All nurses have an ethical obligation to work for social justice. This is what I wanted to emphasize. And forensic nurses are in a position to help ensure that all persons receives the dignity and respect they deserve as they navigate the healthcare and legal system. I hope that this is the only a beginning, and the forensic nurses, once the course is offered, will engage fully and rigorously in research, practice, and advocacy that is explicitly informed and guided by the principles of social justice and medical ethics. And nursing professionals who are on the forefront of front line in the care of patients in emergency service, in addition to having specific attributes to preserve life and reduce sequelae, must collaborate with the preservation of traces present in the victim, in the possible aggressor, the objects and the crime scene. Such traces of high presence in nursing care in emergency services are essential elements for the success of criminal investigation. And take home message, please remember nurses a via media for health disparity. Why I'm telling this is we provide compassionate care, but we take care of victims of violent crimes. Namakariya Nirbhayane Ariyam. Engane Nirbhaya Boyana. And Bombay Poyal Ninga social justice in India through acid victims are there. But when the Aruna, you just think about Aruna, who was strangulated by the nursing assistant because she reported in the malpractice. Malpractice in the veranda. This man was taking the milk and biscuits of pay given to patients at home. He was taking home. This was reported by Arina Denbag, and because she reported it, he strangulated her. And how many years she stayed in KEM hospital as a vegetative form. Recently, last year only she died. You know, have you anybody seen her? No, because I went and saw her in KEM hospital. So I remember how she was, and her photo was there as a young lady. So beautiful she was, and during her death time, how she was. Avarku justice kittilla marikkunathu vere. Nurses were taking care of her, but what can we do? അതുപോലെ വരാതിരിക്കാൻ നമ്മള് ചെയ്യണം. പിന്നെ ഇനി if you are looking at postmortem ചെയ്യുന്നത് ഡിസ്ട്രിക്ട് ഹോസ്പിറ്റലിൽ വരുന്ന ഒരു ബോഡി ഉണ്ടായാൽ ഒരു ഫോറൻസിക് നഴ്സിന്റെ സൗകര്യങ്ങൾ എല്ലാ ജനറൽ ഹോസ്പിറ്റൽസിലും ഉണ്ടെങ്കിൽ they may not have this much difficulty. So health disparity ഉണ്ടാകാതിരിക്കാൻ കൂടി forensic nurses-ന്റെ ആവശ്യമുണ്ട്. That is what I meant, nurses via media for health disparity. And forensic nurses stay again as a via media to resolve health disparity. With these words, I conclude. Thank you for patient listening. Thank you.
Thank you, ma'am, for sharing the knowledge. Okay, please take your point back. Now, Dr. Shashina, please. Thank you, ma'am. With this, we have come to the end of the day of our conference. I hope it was informative and your certificate from this registration desk. Those who are attending only today's conferences. The link for feedback form is shared. Please fill it before you move. One more important notice. Please put all the plastic waste and other materials in the dustbin which is kept outside. Let's now wind up the program with the national anthem. Please rise it.
जनगण अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभाशिष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
Thank you. Tomorrow, all are requested to please be on time. It's at sharp 8 p.m. and we will start the session by 9 a.m. Thank you. Thank you.